So good afternoon, everybody, and welcome to today's meeting of the West Yorkshire Health and Care Partnership Board. Very pleased to welcome you all to my home council of Calderdale and give you the opportunity to see our fantastic town hall, which I hope you have a couple of minutes to look around and enjoy. So it's great to see everybody here. We have a slightly shortened meeting today, so we'll try to make reasonable progress on the items on the agenda. Some of the key issues today include our CEO's report from Rob, an update report on our ambition to increase the years of life that people live in good health in West Yorkshire, a report on our ambition to reduce suicides by 10%, and the work on narrowing inequalities through our approach to inclusive recruitment. Unfortunately, for the microphone system is a bit different today. The microphones on the desks in front of you are not operational, so if people want to speak, we've got roving mics. So I ask people to indicate and take a few moments for the mic to be there. We do need the mics because obviously to make sure it's picked up by the live streaming. We've not been given notice of any questions or deputations today, so I'll take us straight on then to item 3 and remind members of the importance of making sure that any interests are properly declared. We do, of course, have a shared register of interests based on the declarations we each make to our own organisations, but if you have interests in any specific item on the agenda, then please raise them at the appropriate time and we can make sure that they are properly noted and recorded. Item 4 is the minutes of the meeting held on the 5th of September, which has been circulated. Could I just check first of all if there are any points of accuracy on those? Okay, thank you. I'm not seeing anybody. So action log and any action matters arising. Cathy, I think there's one item you wanted to bring up.
Thank you. I'm Cathy Elliott. I'm Deputy Chair of our Health and Care Partnership. There's just one action from the last meeting, which was a reminder to colleagues across the partnership on ways in which the members of the public and staff can raise concerns and give feedback, particularly to NHS services. So we will send another reminder out to colleagues across the partnership this week. Thank you.
Thank you very much, Cathy, and you've reminded me I forgot to introduce myself at the start. Councillor Tim Swift, Chair of the Partnership and Deputy Leader of Calderdale. Councillor Venner, Fiona, I think you had a point. If you press the button there.
Okay, thank you. I'm Councillor Fiona Venner. I'm the Executive Board Member at Leeds for Children's Social Care and Health Partnerships. I just wanted to pick up a matter arising from the last minutes, which was we said we'd have a future agenda item around children looked after, which I'd really like to ask that we do keep on the agenda, partly because we know that children who are looked after traditionally have quite poor health and social care outcomes, but also it's probably the biggest financial risk facing councils at the moment in our region and across the country in terms of the amount we're spending on children's social care because of the increase of children coming into care and the increased costs. So I just wanted to ask if we had a plan for when that would be on the agenda. Thank you, Chair.
Thanks, Fiona. Rob, can you help me on that?
Yes, so thank you, Councillor, for the question. We could discuss this at the next meeting, I think, and have quite a substantial amount to discuss. We've got, in the last month, we've had the launch of Project Hope, which is our specific work to support people leaving care. And myself, the Mayor and various others spoke at the launch of that event. Now that's focused on 16 to 25-year-olds leaving care, and there's some further work around care leavers, people in care that we need to do. The benefits of us having a children's programme, I think, and working collectively across councils and the NHS and the third sector, is that we can focus on this. So let's pick it up next time, I think.
Thank you very much. Any more matters arising or actions from the minutes? Okay, thank you very much. So I'll take us straight on then to item 5, which is Rob's update, and over to you, Rob.
Thank you, Chair. So people have got the report in front of them, so I don't propose that we go through it in detail. There are some things that we should know and that we're asking the Partnership Board to consider today. We are in a context where all of us, I think, are focusing on 3 time horizons. Firstly, making sure that we get through the winter and that we do that, providing as many services safely and efficiently as possible. Secondly, getting ready for next year when we need to make sure that we are continuing to recover services and provide universal care and support for people. And thirdly, getting into the medium term. So one of the conversations we continuously have is about how do we, in this period where we're living with COVID, we've had the cost of living squeeze, and we know that public sector finances face some substantial pressure and distress. How do we get into a position of changing and improving services? So we're targeting our investments where they're going to make the biggest differences. So the report really tries to frame things in those 3 time horizons. And within that, hopefully the Partnership Board will be assured that there's substantial work going on around winter. All partners will be involved in that and take some succour from the fact that we do have reasonable plans in place. In terms of the plans for this year and making sure that we deliver on the finances for councils in the NHS, there's a short couple of paragraphs about the autumn statement and what that said for us. There's very little in there for local authority colleagues, and I know that will be a disappointment to many people in the room. And there's some developments for the NHS. Together, over the last few weeks, on the back of a requirement from our regulators, just want to say thank you to everybody in the room for the work that's gone on around ensuring that we can refresh our plans on the back of additional resources for the NHS to try and make sure that we meet the costs of industrial action, increased inflation, particularly around drug costs, continuing healthcare and so on, and that we can get as close as possible to delivering our original plans on finance, on waiting times, and on making sure we have safe services in the winter. So I just want to draw people's attention to that. I wanted to draw people's attention to the fact that in that medium term, we need to make sure that we're focusing on improvement and innovation by working with the public and our staff in our communities to change the way care is delivered. And there was a landmark report from Professor Chris Ham that was published 2 weeks ago and presented at the Integrated Care System Conference last week, which talks about how do we do that and where do you draw on best practice. And it was heartening to see that West Yorkshire and our place-based focus, our focus on working with citizens, our focus on partnership with the mayoral combined authority was drawn out as good practice, as was the work of our West Yorkshire Association of Acute Trusts. So we're doing some good stuff there with more to do. So I just wanted to remind everybody of that. We know that industrial action has had financial consequences, and I understand there's some breaking news on industrial action today from junior doctors, which will be a disappointment to us and will mean that we need to do some substantial planning around further industrial action for this year. But over and above that, I think it's important for us to recognise that if we're going to have this continuation of good planning together for the winter, as councils are setting their budgets at the moment and thinking about what investments they make next year as we're planning together, it'd be good for the Partnership Board to endorse the work we're trying to do to make sure that we do that as much as possible together for next year so that there aren't unintended consequences from decisions that are taken. I think it's important also that the Partnership Board recognises the significant and substantial progress we're making on health tech in West Yorkshire. And again, with thanks to local partners, so the university in Huddersfield, for example, backing the Innovation Collaborative in Calderdale, Kirklees and Wakefield, and the work that the mayoral authority are doing alongside partners in Leeds for the Innovation Arc, for example. We've got a substantial amount that we can do in thinking about improving the economy and technology for local people. Last 2 things to mention, I think, which are in the report. There's a commission that the Mayor and I have been involved in, and some other people in this room, around creative health. And with Leeds 2023, Culturedale next year, the Bradford year of City of Culture in 2025, developments in Wakefield, the Kirklees Year of Music, we know that there's a substantial amount that culture is doing to help support the resilience and well-being of people. The report tomorrow will talk about all of the evidence and actions for central government and others that could give that a further boost. I can't say any more than that because it's all embargoed. But what I would hope is that we could join together in our ambition to be a creative health system, and that's something that we commit to as part of our developments, irrespective of what happens nationally, because we have the platform to do that. And I also just wanted to flag that the Fair Work Charter and the work we've been doing with the Mayor will come to the next meeting in March 2024. Sorry, at the meeting in March 2024. So I don't know if the Mayor wants to comment on either of those two things, because they're very much enhanced by her leadership, or whether we want to take questions at that point.
Thanks very much, Rob. Tracy, do you want to comment?
Thank you very much for that, Rob. And I'm so honoured to be here, actually. And 2 years into my mayoralty, where I did believe that health was part of my remit, even though I didn't have the strategic powers, that we've got to this creative partnership and this relationship. And I know that it's going to really have an impact above and beyond the size of what we do, because it is that Venn diagram of responsibilities that we can make the change for the people of West Yorkshire. So for me, it's about the health, well-being, closing that life expectancy gap, closing the ill health gap, and the idea that a child born today in Ilkley, say, will live 10 years of a better quality of life than a child born in Batley. There's things we can do in that space to close that gap. And as Mayor, I have responsibilities over housing, so affordable, sustainable housing, cheaper transport, access to skills training, access to better pay. The Fair Work Charter is part of that narrative, making sure businesses pay the real living wage and give well-being and flexibility and so on in the workplace. But I am really pleased as well to be able to work with someone like Rob, who really understands the power of creativity, and that it isn't just a nice to have. It's absolutely about regeneration, about opportunity, about skills, but also about well-being. And I was really privileged to be on the board with Lord Howarth, looking at this challenge of creative health, because we know that already in communities we have link workers, we have doctors who understand that you can, pathway people into art classes for depression and so on, but there wasn't a system in place. And I think our long-term commitment over 3 years to make our region a real early adopter of keeping people out of hospital and keeping people well, I think we'll be able to team and ladle a lot of our responsibilities. So I think it's a really exciting point for West Yorkshire. It's taken me 2 years to get the Fair Work Charter over the line because of the work that we had to do with businesses to understand what would make them sign up to it. But also this creative health approach has been a manifesto commitment, and I'm really pleased to have been able to work with all of you and our local partners as well to understand what we can do. And also Huddersfield University, thank them for their vision as well and the way that they worked so hard to get it over the line. And can I just thank Fatima, who's standing in for me, I think, in Parliament at the launch, is my understanding, of the report. So I think this is just the beginning of a fantastic opportunity for our region to use creativity and the powers of my office and the powers of all of you to make West Yorkshire a better place to live and a better place, if you're unwell, to get well faster. Thank you, Chair.
Thank you. So there's quite a lot covered in Rob's report. Any questions for Rob or any comments on the issues raised from anywhere? Yes, Fatima.
Afternoon, everyone. My name's Fatima Khan Shah. I'm the West Yorkshire Inclusivity Champion. It was just to build on the point regarding creative health and to acknowledge our commitment to personalisation, which is a massive enabler of finding alternative methodologies and treatments for people with long-term conditions as well as mental health and wellbeing issues. And this is a really great opportunity to consolidate and further embed the work that we've done so far.
Thanks very much. Susan, Councillor Hinchcliffe.
Thank you, Chair. Thank you, Rob, for noting, obviously, the autumn statement and the impact that's had on councils. It wasn't actually just nothing in there. There was actually a cut in there for local authorities. I think people need to be aware of that. And increased costly burdens on councils as well, which obviously lead to an additional cut on top of the cut. They announced about 3.4% a year for public services. We're unprotected as a department. So I think that's, it's really quite serious, and thank you for noting that's serious for all partners in the room as well. I think people need to be aware of what's coming. Secondly, obviously yesterday was an announcement about, I just want to congratulate us all really, because there was an announcement about a government fund coming out to support those authorities not doing very well on winter emergency funding. Congratulations everybody, we're not bad enough because none of us got any money in West Yorkshire for that. So we're obviously being punished for our success in the region, but I just thought I'd make that point. Thank you.
Thank you, Susan. Michael?
Is this on? Yes, I'm Chief Executive with the Kirkwood, which is a hospice provider in Kirklees. I also represent the West Yorkshire Hospice Collaborative at this board. It would be remiss of me not to point out the role that hospices play in creative health and how important creative therapies are as part of our own service models. So again, I hope you're thinking about us playing into that agenda. And again, I'll use the opportunity just to let everybody know that the Kirkwood recently released a charity single, which is a cover of Labby Sifry's It Must Be Love, and that's available for purchase on all of your usual streaming platforms.
Thank you. No, I did that wrong. Thank you. Great to hear another contender for the Christmas #1, let's hope. Thank you. We'll do all we can to push you anyway. Rob, is there anything you want to come back on?
Just to Councillor Hinchcliffe's point about the additional resources for local authorities in areas that are struggling with winter pressures. I think we continue to make sure that as we discuss matters with national bodies, we reinforce the requirement to incentivise the right things.
Thank you, Tracy.
Just on the winter pressures, you may know that the Mayor's Cost of Living Fund was announced last year, £3 million to go to local authorities at speed to provide warmth, food and support for poor mental health and debt advice. We had the audit of the first £1 million, and I can't tell you the impact was phenomenal. We'd hoped to reach 3,000 people. We reached 6,000. So we're consolidating the final 2 million, and that's going out as a matter of urgency to local authority partners who know exactly how to use this money. And it's the power of devolution that is working in West Yorkshire that we can do that at speed to support local authorities in what is a really difficult time.
Thank you very much. Cathy?
Thank you. People in the room know that this has happened today, but I think for anyone watching live the meeting or perhaps on record afterwards, that going to Councillor Hinchcliffe's point on the fact that the situation that we're in, looking at our finances across the public sector, that we did have a private development session earlier today, whereas health and care leaders, including health and wellbeing board chairs and chief execs in the NHS, that we've come together to look at risks and the opportunities in our respective places and services and across the whole of West Yorkshire. So we know it's a live debate, we know it's a live discussion. Rob, as our lead chief exec, talked through about how our plan and our 10 big ambitions are still sound and robust for the next 3 to 5 years, but also that we've coming together to look at the risks across the system and the consequences as well. So I just wanted to put that on record, Tim. Thank you.
Thanks very much, Cathy. I endorse it's a really important piece of work, and really important that our system is working together in that way. Perhaps I could also add for information, and people may have seen that, linking this to the next item really, that Rob, Cathy and I submitted a joint a joint letter supporting and welcoming the government's proposals on smoking cessation and the creation of a smoke-free generation. I think it's one thing that I would say is genuinely brave of the government, but I think also seeing the example of what's happened in New Zealand, where they're just talking about reversing that policy, it emphasises that it's not enough to see it as a government policy, that it needs all of our commitment and pressure to make sure that elected representatives, MPs particular, but others as well, understand the importance of value of this, and we build up a real, a really strong social and community commitment to seeing that policy through. Rob, anything else you want to add? Robin, yeah.
Yeah, it's Robin Tuddenham, a place lead from Calderdale. Just building on the arts and health, creative health, and I couldn't remiss of me not to say that we see ourselves as a bit of a home for that in Calderdale, having many years ago repurposed a site, the Mental Health Trust, as artworks to support people with mental health issues. And there's a very hard edge to this. This isn't something that's a luxury. It's actually about changing people's lives at end of life. But actually we have this project with children, mothers and fathers, and your first song. There's something about voice, song, learning, creativity to give people hope and opportunity. And there's also a hard edge around the jobs and the health and wealth and healthy lives you'll create through the respective years of culture and city of culture. This is about the determinants of health, and it's actually about bringing people together. And we're holding this meeting at a time when our communities are suffering strain, not just financially, but because of international events, and bringing people together around common purpose through creativity. And recently an event with organisation Solutions Not Sides, doing work with children around the Middle East conflict, bringing people together around faith and understanding. And actually this is really hard-edged stuff about giving people not only good and better lives, but actually preventing people becoming unwell. So it's really important to us. Thank you.
Thank you very much. Not seeing anybody else indicating, so we're happy to receive Rob's report and to note the various items for action and decisions within it. That's appreciated. Thank you very much, everybody. So item 6 is about our ambition to increase the years of life that people live in good health. As we've been reviewing the way the partnership works, we agreed at our last meeting that one of the things we would do is have reports each time on one or two of the 10 big ambitions for the partnership and the system. And this is the first of those reports. So I'm going to hand over to Dr. Sahel Abbas and Sarah Smith to introduce this. Thank you.
Thank you. I'm Dr. Sahel Abbas. I'm a GP, Director of Reducing Inequalities in Bradford District and Craven, and Deputy Medical Director of West Yorkshire. So we are here today, and thank you very much for inviting us to discuss this item. In 2020, as a West Yorkshire system, we set this ambition that we want to reduce the gap, the inequalities gap in the life expectancy, the years of the people live life and healthy life between our most deprived and most affluent areas. So we are here today to provide a brief summary of, because it can't be more than a brief, there's so much to discuss, a brief summary of the work, the journey of the system in the past 3 years of improving population health program of our West Yorkshire system as a whole. And we are also going to describe this within the context of all the things that we are discussing in terms of our post-pandemic world, rising poverty, financial deficits, all of those challenges. And we're going to have some recommendations and a request for your support for future. But before we do any of that, we are going to share a dream with you. So last month, we had our Health Inequalities Academy, West Yorkshire Health Inequalities Academy 2 years event. And we closed it with a dream. So we're going to share that. We're going to start it with the dream. So we are people of West Yorkshire, and we have a dream. We have a dream of a place where how long and how healthy we'll live will not be determined by who we are, where we live, or how much we earn. Where a child will not find it impossible to reach the full potential due to poverty, lack of education, or safe environment. And this pattern will not be repeated from generation to generation. where children will not be victims of trauma, leading to a downward spiral in their adult life, where no child will die because of mold in their house, and no older person will be admitted to hospital with medical complications arising from loneliness, lack of food, and lack of warmth in their house, where a child will not go to school hungry, and no woman, irrespective of ethnicity and deprivation, will have a worse pregnancy outcome and lose their baby, where people will not be homeless, where consequences of adversity, trauma, and societal failure will not be mistaken as lifestyle choices, and people with learning disabilities will not die 30 years younger than the general population. A place that every migrant and every refugee will call home. We have a dream of a system where we shall align all our efforts, our resources, and our accountability and governance mechanisms to improve population health and reduce inequalities, where we will embed equality and celebrate diversity, where everyone will belong and no one will need to fit in, where we shall truly plan, design, and deliver our services based on our population needs, and we shall invest in our frontline workforce in prevention and in communities. Turning that dream into reality is the ambition of our West Yorkshire Health Inequalities Academy. We shall help everyone to develop the awareness of inequalities and take action that is within our sphere of control. We shall develop networks and relationships, support mechanisms, and collective influence to become advocates. We shall hold each other and our leadership to account, and we shall challenge and improve the way we prioritize. And above all, we shall develop hope, as it is hope that will give us the strength to achieve these seemingly impossible goals. With that dream, I'm going to hand over to Sarah to tell us the reality and the journey.
Thank you, Sal. I always think we talk about public health as the art and the science of creating good health, and I feel that Sahel's quite expertly given us the art there, so now we're going to come on to a bit of the science. So for those of you I've not met before, I'm Sarah Smith. I'm a consultant in public health at West Yorkshire Integrated Care Board and Associate Director for the Improving Population Health function. Work really closely with Sahel on the inequalities work. So we've got the paper in front of you. So we're not going to go through it in lots of detail. We're going to pull out some of the key points before Sahel summarises with the recommendations. But what we really wanted to kind of put across is this ambition as our first ambition really as a health and care partnership really sets the tone for the work we do. And really helps us think about that there are 523,000 people in that IMD1, so in that most deprived decile. So really thinking about those people, over 500,000 people who live in West Yorkshire who are experiencing poorer health outcomes. And the intersectionality that weaves into that, so the overlapping the other characteristics. So 42% of people in West Yorkshire who report being from an ethnic minority background live in the most deprived decile as well. So when we're talking about deprivation, we're also thinking about other characteristics that overlay with that. So since setting the ambition in 2020, we've obviously had the pandemic, and we've also kind of felt the impact of the cost of living crisis, both on an individual level, but as a health and care system as well. So the paper and the recommendations focus on what actions taken place, but where we want to go next. In terms of understanding the gap, we looked at what conditions drive those gaps in life expectancy. And we see the conditions that are driving the gap are ones that are actually preventable, ones we can do something about if we work in partnership as a health and care system. So things like cardiovascular disease, lung cancers, respiratory ill health. And those are the conditions driving the gap, the health conditions, but there are lots of things that underpin that. And that's, leading on from the development session we had earlier, really thinking through what are the factors that drive that ill health. So we've done lots of work on the determinants of health, forming partnership with the combined authorities, really good evidence of that. We've got combined roles, consulting in public health roles, and obviously our inclusivity champion role as well, where we can really kind of join forces and take action on the determinants of health and really focus on the opportunities, the inequalities in opportunity that people face within West Yorkshire. So things like the Fair Work Charter have made inroads there. And then if we look at the building blocks for good health, really looking at what are the risk factors that make people poorly in the first place is something we've focused on as well. So smoking, we've just touched on that we've signed a letter supporting the government's ambitions around smoking, but smoking is one of the risk factors that really drives ill health. And I'm proud to say in West Yorkshire we've reduced our smoking prevalence from 15% in 2020 to 13.1% in 2022, but it remains higher in some of our poorest communities, and it remains highest in our routine and manual labour workforce, and it remains higher in our social housing providers, people living in social housing as well. And again, we've reduced our smoking at time of delivery for people who are having children from 12% to 9.5%, so a real significant reduction. But if you live in that most deprived area, you're still 10 times more likely to smoke at time of delivery than if you don't. So there's still work to do. We've also made really good progress on earlier disease detection and supporting people who are on the cusp of being diagnosed with disease. So people living with diabetes or risk factors for diabetes, the services we've put in for those people are disproportionately reaching people in our most deprived communities. So that's a really positive difference we're making. And as a system, we were recently ranked third out of all 42 ICBs nationally in the work that we've done in a positive light to on CVD, cardiovascular disease prevention. But again, there's more we can do on inequalities in both of those spaces. So they're just touching on some of the outcomes that we've worked towards. But in terms of action we've taken as a system, so Hal touched on our Health and Equalities Academy. So we've worked over the last 2 years on how we can really add capacity, capability and intelligence as a system overall to reduce health inequalities, both through increasing our understanding and our curiosity through a whole health and care partnership to take action. In doing that, we've launched a Health Equity Fellowship, which is now going into its 3rd year, and we've partnered with North Yorkshire and Humber Integrated Care Board on that as well now. So it's really growing legs, and we've had some really positive outcomes from that, and people from multiple sectors, not just the health sector, across West Yorkshire on that fellowship. In March this year, we became a system of sanctuary, and that shows the work we're doing to support people who are refugees and asylum seekers in West Yorkshire, to show we're a system that welcomes those individuals. And there's a real strong action plan behind that work as well. So it's not just about making the statement, it's about the work we do. We were one of the only systems in the country to ring-fence our core 20+5 health inequalities resource. So in terms of how we're allocating resource, we're putting our money where our mouth is on the inequalities work. And we're doing really well on our recording of data so we can better understand inequalities, particularly around ethnicity, although I would say there's more work we can do to help us understand that system. And finally, we've just launched an Inclusion Health Unit. So we're doing, that's a unit to support people who are small in number but great in need across West Yorkshire. And it was us looking at how we can focus on population groups that make sense to look at scale. So again, we've talked about refugees and asylum seekers, but also homeless population and gypsy and traveller populations are groups that we've worked with through that Inclusion Health Unit. And that's something we will be growing over coming years. So in terms of where we want to go next and what the paper recommends, there are some really specific areas of focus. We're looking at where we can really add value and really think about what's the collective action that we can work as a system on. We recommend that we maintain our strong links with the combined authority and really work on those determinants of health that drive all of these factors. So opportunity, inequalities and opportunity through our workforce, through housing and through our economy. We recommend we take a more whole system approach on smoking and smoking cessation, and we think there's some real good progress we can make on that as a whole system. Similarly for physical activity, there's a lot more connections we can make with the health and care system there. We're due a major condition strategy launch in the new year, focused on long-term conditions, and what we'd really want to do as a health and care partnership is ensure that's focused around population need, not necessarily just what we're asked to do by the national team, but really looking at what that means for West Yorkshire and how we can make a difference. And finally, I've mentioned the Inclusion Health Unit, and we think there's lots of opportunity there to continue to work collectively to support those population groups. In order to do all of that, in addition to all the excellent work that's happening in our local places and communities to address inequalities, all of this is underpinned by the need for an equity-based system. So Sahel's just going to cover off the recommendations around that.
Thank you. Oh, okay. Yeah, so equity, last year as a West Yorkshire Health and Care Partnership, we did a piece of work with London South Bank University and Sussex ICS, a program called Universal Healthcare. The report is published this year, and there is a lot of learning in that report. But the fundamental thing is it's what it's saying is that equal is not fair, and the NHS equal flat offer, it worsens inequalities. And if we want to truly reduce inequalities, we need to review our processes of how we invest, plan, design, and deliver services. Something that we call, as you all have heard from Michael Marmot's writings, as proportionate universalism. So yes, we need a universal offer, but it has to be proportionate to the needs of the communities. And that is what we mean by the equity-based system, not based on equality alone. So how we do that? So now we have a reality. We have a reality here, and that is people are dying 10 years younger. People are spending 20 years life in ill health because of who we are, where we live, how much we earn. We have a dream of a system where that will not be determined by those factors. And there is a journey in between. And as Rob Webster many times he says, many systems think that journey can be, we can travel it by magic. We can't do that. We need resources. We need to invest into our communities. We need to invest in projects that we need to invest in evaluation. We need to invest in system thinkers, in influencers. We need to all those resources, and that is where the targeted health inequalities fundings, like Core 20+5, ring-fenced fundings, etc., comes in. So we need to make sure. Yes, the times are tough, but we need to make sure that we, as a system, we commit to that. But that is not the end. That's a means to an end. Because if we look at the 4 aims of the ICS, and I usually say there are only 2 aims. The 2 aims are improved population health and reduce inequalities by using your resources wisely and investing in the wider economic development of your partnership. So in order to do that, in order to really turn the tide on inequalities, we need to look at the totality of our resource. And that's the equity-based system. But how we do that? So we came with is the 3A. So it's essentially one thing is accountability. Any system, a mature system, is really high up on support mechanisms, and we are really high up on support mechanisms as a system. But also a mature system is also really high up on accountability, using our assurance and governance mechanisms to make this business as usual, not just on the edges, but really making it at the heart of how we do things here. And that is we need to look at our accountability assurance mechanisms, our board assurance tools, and there is a lot we can do in that arena. NHS England, just last week, they published a guidance for the ICBs, for trusts to report on their progress on health inequality. So we have a lot of things that we can utilize. We need to make sure that we are allocating proper resources to embed this work, and we need advocates. We need advocates. The advocacy, people who are actually who are using their influence to create a collective influence, and that is all of us here. Also, the people we are developing as in our health equity fellowship scheme, in improving population health fellows, everyone. So we need that. So that takes us to the recommendation in the paper, and that is to acknowledge the work that has happened and is happening across West Yorkshire Health and Care Partnership, support the continued focus on wider determinants of health with local authorities, with West Yorkshire Combined Authority, Inclusion Health Unit, Inclusivity Champion. Reduce the inequalities in key risk factors, smoking and physical activity, as Sarah said. The response to the major condition strategy and linking it to the core 20+5 work that is already happening, and a commitment and work towards creating the equity-based system across West Yorkshire. So thank you very much.
So, Sarah, thank you very, very much for that presentation. Questions and comments or views? Yes, Kim.
Thanks, Hale and Sarah. Brilliant presentation. I just wanted to flag something that we are looking at in the ICB at the moment, which is the risk to the sustainability of the VCSE in terms of contributing specifically to this agenda. So we have done some analysis on some of the NHS contracts which are to the VCSE, and that is showing quite alarmingly that around 70% of those are due to end by next March. We haven't started that analysis or been able to look at the data for local authorities, but I would take a guess that that will be looking quite gloomy as well. Specifically, I think we need to think about the grassroots organisations that operate across West Yorkshire. We're very, very lucky to have 15,000 VCS organisations in West Yorkshire. 95% of those are small, which in their nature does that really, really deep inequalities work with those communities, the most deprived communities, and also the communities that we're not reaching through our statutory services. So there is some specific work that we could do to look at how we de-risk some of that, recognising that the very difficult financial situation we're all in.
Thank you. Fatima, I'll take 2 or 3 if that's okay.
How can I not be enthused by that presentation? I mean, I think West Yorkshire is a place where dreams come true, Sahil, and we've got to keep the hope, haven't we? A couple of reflections on what you've said. I think that the first one, absolutely, we need to acknowledge that if we're going to be courageous about this, then we need to be realistic about the resources we've got, and to recognise that not everybody experiences health and care in the same way. And for us to take positive action, that means that we need to give up something, and we need to reaffirm our commitment to that. The second thing is the opportunity that comes with working with the combined authority. And I'm really proud to work for the Health and Care Partnership, but I think the opportunity of working within local government and to influence the agendas of things like skills, the economic work that Tracy Almeida has done in bringing jobs into the region, etc., really gives us an opportunity to go above and beyond the things that really matter to people. So Rob was saying in the development session earlier, you know, what matters to people is somewhere to live, someone to love, something to do. I mean, it's not that hard, is it? But creating opportunities for people to have those things is something that very much we can work in collaboration to make happen. I suppose my queries are there opportunities for us to really evolve this way of working, to recognise some of the areas that aren't within our gift as a health and care system, but may need influencing with a softer perspective? So things like discrimination, which obviously as the inclusivity champion I've got a massive interest in. Also violence. So Tracy and I were at a round table with a number of chief executives who are leading on organisations against violence against women who experience domestic abuse and sexual violence. And one of the things that they really told us was the importance of developing capability to enable them to deliver systemic interventions that are sustainable. So is there an opportunity for us to work collaboratively with the amazing work that Emma Irving leads with you, Sarah, on Trauma Informed, to really develop capability in our VCSE organisations to really deliver this? Because some of the things aren't necessarily things we directly deliver, but we could really influence to deliver some positive outcomes. And then the final thing as well is making sure that the services that we deliver are also culturally competent and available for everyone. So a stat that I heard this morning, which blew my mind, was that people that are homeless are 4 times more likely to use our emergency services, which, you know, is unsurprising, but still something that we need to work quite holistically on, and I wondered whether there is more that we could do with our partners and the work that we do within local government to really influence that with some really systemic and meaningful interventions. And then the final thing I'll say is about cultural competence. We talked about creative health and personalisation. Another agenda that we're supporting is sports for health, and recognising that actually if we want people to take a proactive ownership of their health and well-being, we need to make sure that services are inclusive for people's faith and cultural needs. So if you're asking a woman like myself, who is a Muslim Asian woman, to go into a mixed venue to perform sports, they're less likely to utilise that than a specific group that caters to their needs, which will deliver really positive outcomes. And then the final thing, which I really applaud, is the advocacy and the influencers. So if we go back to COVID, the learning we had wasn't just about the message, but the messenger. So how do we develop that capability of using people's lived experience to lead the change? I'm an example of the possibilities that comes with giving people that opportunity. What more can we do as a health and care partnership to make that happen?
Thank you. I want to come back.
Okay, thank you very much. Well, there's a lot in there, isn't it? So,
yeah.
Yeah. I think what I would say, Fatima, one thing is we usually think that there is a moral and ethical case to work on inequalities. Well, definitely there is, but there is a very, very strong financial case to work on inequalities. Inequalities, health inequalities, healthcare inequalities, they cost us. They cost us hundreds of billions of pounds every year, and really working on that, we can really use our resources wisely, and that goes with that principle or ICS aim. I think equity-based system is not just a system where it will be using you put money differentially. It's actually a system where we are going to develop services according to the population need, so that culturally appropriate for that postcode, for that community, for that religious population, that is equity-based system. It's not just money. It's using what we already have. And we have shown this. We have shown in Bradford, for example, culturally appropriate eye-apt services. We have increased the uptake from our Muslim communities and Asian communities by, I think it goes from like 20-30% to more than 60%. So that is how we can create an equity-based system, and we can still within our financial resources. In terms of obviously working with, we also have a lot of stuff that is going on, like across West Yorkshire. We have this work that Carol McKenna and James, they are leading on transformation and efficiency in terms of how do we look at the totality of our resource. In Bradford District and Craven, we have started the work of narrowing the inequalities and looking at the whole funding and the value-based healthcare. So a lot is happening, and obviously you work very closely with us anyway. VCSE, definitely, it's that again something in universal healthcare. One of the theme is that we really need to invest and empower our voluntary and community sector. But that again goes with, yes, there is an immediate need, and we need to make sure as system leaders that how do we continue that investment and not destabilize. But actually, if we just continue doing that, then year after year we'll be having the same conversation. It's that short-term conversation, but then that long-term system conversation where we actually create the VCSE and whatever we think works as part of our care pathway. And we need to move from year after year non-recurrent funding to really recurrent funding streams. And again, that goes to how we design, develop, and evaluate our services.
Yeah, just coming on a couple of points, you covered it really well, Sahel. On the VCSE point, to kick off, we can't do this inequalities work without voluntary and community sector. I mean, the trust with some of the population groups we're working with, we just don't have it. We don't have that legitimacy. We don't have that trust. So we need to find a way to increase the sustainability there. I think we can support it through supporting evaluation and not being too overzealous on what we require in every specific thing for evaluation. That's some of the feedback we've had from the sector as well. But so I think it's understanding what role we can have around financial sustainability, a West Yorkshire pound potentially, and supporting evaluation. I think there's some practical things we can do to support the sector within the current constraints and the advocacy piece. I think, Fatima, just to pick up on, yes, absolutely, we need to collaborate on this, and we do, and we will more. And I think as painful as it has been for some colleagues going through the operating model work, I think it gives us the opportunity to reflect on what we're doing well and what we need to do more of. And I think some of this collaboration piece with the combined authority on more of the determinants of health is where we can increase that. I mean, some of the work on, you touched on homelessness, some of the work through the Inclusion Health Unit that's coming up already is giving us some really good opportunities to fund work with homeless communities. So a piece we're working around early respiratory disease diagnosis, which we know is a specific problem, and a piece of work with hospices in Leeds around end-of-life care for people who are homeless. So there's definitely a need that I think we're picking up more and more through this kind of work.
Thank you. Tracy and then Rob.
Thanks so much for that. Unfortunately, I can't see you because of the layout of the room, but it sounded brilliant from where I was. Thank you. I just wanted to make a contribution around housing. And for me, growing up in social housing in Batley, in a council flat with my sister and mum and dad in a 2-bedroom flat, that security enabled me to have the life that I've had, that I haven't felt vulnerable. We didn't feel vulnerable to landlords or whatever. So I've been able to as mayor to say, I want to build 5,000 affordable, sustainable homes. Now, given the economic crisis and inflation, etc., it has been a reach, but I am pleased that one of the great outcomes of that manifesto pledge was that the West Yorkshire Housing Partnership with housing associations came together, all of them across West Yorkshire, to help me deliver on that pledge. And I just wanted to offer to you, as the ICB, the opportunity to maybe work closely with us in that soft power, in that convening space, that we can tackle things en masse, because we have those groups in the room, and Guinness have just joined that partnership, and my Dementia Ready task force has been helped me deliver on that. We're looking at solar panels for social housing through that partnership. It is a great space because everybody's come together with a common endeavour. So I do think devolution gives us that opportunity to convene, and we really. It is pleasing to see that in the autumn statement that the government lifted the cap on housing benefit, because we know that so many were forced into homelessness because they couldn't pay private rents. But it was quite galling to be on site in an estate that, because of our Brownfield fund, housing fund, we're able to build these lovely, affordable homes. And there was a family of mum and dad, 2 kids, baby on the way. And that family had been made homeless by a landlord who was worried about the no-fault evictions coming in. So he evicted them anyway beforehand. And I think we potentially may see a fair bit of that. So I just wanted to make the offer to the ICB that we have this forum. We are working quite collaboratively, very collaboratively together. And my mission to enhance social housing across West Yorkshire, working with our partners who are doing a magnificent job under great duress, is there for the taking. And the partnership really does want to deliver.
Thank you. Rob, and then Susan.
Yeah, thank you for that. So to really support the Mayor's comments, sounds, one of the things we believe is that we should connect the system to more of itself so we can make a bigger difference. That's a really great example. Just 3 practical points, I think, that we might want to ask Sahil, Sarah and the team to take away. So the first is that we've got a range of partners in the room who don't appear much in this report, who have done some substantial work on inequalities, and that's our trusts. So if I look at Keith Ramsey and Mid Yorkshire Teaching Trust and their work on the pathway for learning disabilities for people waiting for operations, the 12-week pathway. Look at Brendan and the work that Caldale and Huddersfield Foundation Trust did on learning disability, ethnicity, deprivation and waiting. And Mark Brooks and the work that his trust has been doing on access to mental health services, based on population characteristics and protected characteristics. There's a lot of work going on that people could bring to the party, which doesn't come out as strongly in here as I would like, and that might just be me in the way that I'm reading it. but we need to harness that in the work that we're doing. The second is that the recommendations speak to the right areas, but there are some defined populations who we know will face inequity, particularly people with a learning disability. And the shocking health outcomes that you mentioned, I think, in your report, and the continued failure for us to provide good access sometimes for people with a learning disability. So I would hope that we could target some populations through those sorts of characteristics and population health management, which again I don't think we talked about much. And then the third very practical point, I think, links the previous decision that we took around joint planning and working together. So if we hear Kim telling us that 70% of contracts for third sector organisations are up in March, and we're doing some joint planning, are we taking that into account in thinking about the decisions we're taking? Or are we taking the easy choice of saying, well, some contracts are coming to an end, so we won't, we'll think about those differently from what we do in contracts that are ongoing. Now, if we take an inequalities lens, we wouldn't do that. We wouldn't make an easy choice about what we stop and what we continue. So I would ask that we decide that the work that goes into that joint planning takes that inequalities lens and the third sector into the work.
Thank you, Rob. Susan?
So we need to turn the microphones off, I think. Do you need to turn your microphones off? Oh, thank you. All right, lovely, thank you. So yes, thank you for that. Obviously it's important work that we know well in Bradford and have seen it develop over the years, and obviously very supportive of it. You just on the conditions for an equity-based system, recommendations in number 86, says we continue to ring fence core 20+5 resource in 24-25. Obviously we just started the meeting talking about financing. Is that going to be possible? And secondly, again, from a money point of view, if we always say that this is their work and they're doing this very well, there is a tendency then for nobody to do anything else about it. And what we really need to do, surely, is get this work to influence everything that's happening, and everybody needs to make it part of their business, and then we have a bigger impact for the learnings that they've made. So how do we make sure this is mainstreamed? And actually, is it practical to say that this is ring-fence for 24-25, or are we going to have the money to do that? Really basic question, thank you.
Thanks, Cathy. You'd indicated next.
I'm going to segue very into a similar thing that Councillor Hinchcliffe's just been talking about. There were 2 points in the paper. One was about Keep It Local campaign, which I think is all of us in this room work for organisations that procure and spend a lot of money. And I wondered maybe you could talk a little bit more about that, which I think complements what Susan was talking about there, how we can all make a contribution. And then there's I think this is a specific ask of the NHS West Yorkshire around NHS commissioning being around equity, and what's in our power and what we need to influence further, which I think we can then take, Rob and I, with our colleagues on the NHS West Yorkshire board into our next meetings in January and March next year. So I think there's this is probably one of the second example of how broader strategic policy work that's discussed here can then also go in with a commissioning angle into NHS West Yorkshire. So I think that's how we commission things and how we spend our money, be really interested in. I also have questions around partnerships and a similar thing to, as Susan said, if in the NHS we're being encouraged to fund and work on Core 20+5, but how do we scale it up and make it mainstream? But how do we spend our money better and how do we commission it? I suppose are my main two questions.
Thank you. So I'll come back to Sahel and Sarah.
Thank you very much. Again, there's a lot in there. Thank you, and a lot for us to take back. I think Rob's point about the creation of the system learning space, where we are learning from the work that is happening. Some of it, and quite a lot of this is captured through the Health Inequalities Academy. So we recently launched the Health Inequalities Academy dedicated website. So we are looking, we do take this learning and put it for as that space. But we need to do more on that, because it's not just sharing good practice. It's also looking at analyzing what was the component that actually another system can take and embed. And that goes back to our evaluation and analysis and all of that work that is happening. We work closely with WIAT, Association of Acute Trusts. Again, in terms of our improving population health fellows, loads and loads of good work comes out of that. So we also have that repository of work on our website. I think the thing around, yes, that is the dedicated team. I think that is very what Councillor Hinchcliffe has said. It's everyone's business, but our business is to make it everyone's business. So that's the fundamental of the core team, where we have this dedicated resource, a few people in Bradford, like Reducing Inequalities Alliance, in West Yorkshire, our Improving Population Health Program, and Health Inequalities Network, that those people whose job is to facilitate the system thinking, system learning, and making it everyone's business. And that is how we describe it as three circles. So in the innermost, that's our core team, a few people, but then it's the network around, or the alliance in Bradford, as we say, and then it's everyone. And everyone is even if we just say everyone is our workforce, it's 30,000 people in Bradford, it's 100,000 plus across West Yorkshire. So if we can make that goes back to the I of inequality, if we can make everyone understand what their role is in tackling inequalities, and we're working on that. Core 20+5, yes, and thank you very much for raising that. That is the ask in Core 20+5, ring fence funding, and that goes back to, we cannot make this journey by magic. We need resource, and we need to look at the dedicated resource. Core 20 plus, the thing around the health inequalities, even the very basic health care inequalities like cardiovascular disease, hypertension, cholesterol, they take at least 3 to 5 years to show impact. When it goes to the lifestyle factors, it is more, it's like 10 years. When it goes to the wider determinants, it's like a generation where you will see. So essentially how we make sure that we are targeting that funding, and we are holding our nerves for at least a few years to actually let these projects run their course while we are putting the evaluation mechanisms and all that in place. So yeah, we will really request the board to around that ring fence funding.
I'm working. Yeah, sorry, the light just doesn't work on it. There we go. So just to pick up on the hospital's point, I think, and then I'll come back to the funding bit. I think we've got really good collaboration with a consultant in public health who works with the Mental Health Provider Collaborative, who's doing lots of excellent work on inequalities in relation to learning disabilities and severe mental illness that we work closely with. And there's some amazing work, as you've pointed out, Rob, going on in the Acute Trust, in addition to work of the Health Equity Fellows, which should have been in the report, and I'm aware of it, but we do also have an acting consultant in public health who's really keen to do some work with the Association of Acute Trusts, and that's in scope for the new year. So it'd be great to kind of join forces a bit more and have some more of that direct public health sort of systems input there to support that. So that's a bit of an offer that Richard did know about. But I'll just... in terms of the resource, it was when we first had the discussions around the Core 20+5, the request was for 3 years funding. I think that is possible in the current financial envelope with support from the board. But it's... yeah, we've had discussions with the Director of Finance who is supportive of that, but it would be good to get the sign-off here and then to take it back to the Integrated Care Board in the new year just to get that final kind of assurance as well. But I think, as to Sahayal's point, to kind of have that, the progress that we want to make on the inequalities kind of takes that 3 year, and that conversation we've had around sustainability as well, particularly a lot of the funding that goes into voluntary and community sector and other projects that need that funding to continue. But that is part of that wider, 0.5% of the total pot. So this feeds into a wider discussion about how we influence commissioning to work in a more equity-based way. It's an important point, but it's it's a drop, yeah. It's sort of a drop in the ocean, isn't it, in terms of the overall pot.
So thank you for those responses. I just think the point about Wyatt and the mental health providers and Yorkshire Ambulance Service actually done some really good work is we're starting to see culturally that people do see it as their business, which is something we should treasure really, because people aren't just saying, well, we need to put people through the system as quickly as possible. So we've got to put the right people through the system as quickly as possible. On the money, I think that, you know, we have some requirements as a partnership around investments, and we have some choices to make around what we invest in. So if we take the mental health investment standard, we have to audit. I've just signed off the bill for auditing this. We have to audit the fact that we invest disproportionately in mental health services in line with national policy. The Core 20+5 money doesn't have the same obligations on it, but we could decide to treat it similarly, but also recognise that there's no guarantees on anything at the moment, given the financial pressures that everybody faces. So there should be, I think there's something about what's the intention of the partnership. The intention is to invest the Core 20+5 money, and if we cannot, then we should bring it here for a conversation about why not and where it fits in terms of the order of prioritisation. But I think given the scale of challenge that everybody's looking at financially, I know that councils are currently looking at some very difficult decisions. People are being made redundant. The ICB is making people redundant. There's the context we're in is such a tricky one. But that intent and that intention to invest the Core 20+5 money, I think, should be there. And then as we look at our prioritisation of investment and resources, if we cannot do it, we have to have the conversation here about why not, and then make that decision and choice.
Thanks very much, Rob. Katie?
I'd really welcome after this meeting just to follow up on that keep it local approach, and I think on how we all in respective organisations can spend our money more locally into local businesses, because it has a triple effect in many ways. So I'd suggest if that could be a follow-up after the meeting, and then we can all respectively take that away, whether it's within NHS constraints or not. Thank you.
Thank you very much, and thank you, Sahel and Sarah. So I think if we're happy to agree the actions, but also to note, I think Rob's very helpful suggestion about how we handle the Core 20+5 money issue, and also to note the examples of progress that are going on in the various trusts and so on, again, that Rob referred to. People are okay with that? And Tracy's offer in terms of the housing as well. Yeah. So thank you very much. Everybody's okay with that? Thank you for that discussion. So item 7 is our patient and public voice item. So I'd like to welcome Ali, Alison and Seb from Leeds Mind. Ali, I understand, is the project coordinator for Leeds Mind, and Alison and Seb are both volunteers for the project with lived experience of suicide. This project was developed to draw on lived experience, to reduce stigmas, raise awareness, champion the voice of lived experience, and challenge and influence decision makers. And you're very welcome, and I'll hand over to you to present.
So, never done a meeting like this before, so thank you for having us. I'm Ali, so I'm the project coordinator, and as has been mentioned, the project has put out a variety of different smaller projects, resources and different partnerships across West Yorkshire over our 2 years. And everything that we've made together has been entirely co-produced and have all come from a place of lived experience as well. So I've worked with, it's been up to 20 volunteers at a time. Is that all right? And everyone has got lived experience of being impacted by suicide in some way. So for some people, the project has been an opportunity for them to sort of action some of their grief. And for others, it's been a way to reclaim power from, you know, being involved in a system that's made them feel quite powerless over a period of many years. I think for everyone, there's been a real strength in that sense of collective voice with everything that we've made together. So that in itself has been quite a healing experience. So I've got Alison and Seb with me in person today, but as I say, we've got lots of volunteers who wanted to be here who couldn't. So I asked them if there was anything that they wanted to send to me to read out, because it'd be nice for you to hear from them directly. So I've got 2 things to read today. The first is from a volunteer who's local to Calderdale, actually. And they've got experience of suicide bereavement, and they wanted to share what the impact of that has been like for them and why they got involved in this project. So I'll read that to you now. It was like a bomb going off in my world, with the repercussions being fragments scattered all over the place. things would never be the same again. Broken fragments peppered our world. Life for myself and family changed forever. With natural deaths, the family usually know a cause, whereas for a death by suicide, there is always a why, and the family never know the why, and this is immense. The day when a member of the press turned up on the doorstep dressed in a long dark coat, shiny black shoes, and a tie like a funeral director, without initially introducing himself, was hurtful on another level. Coincidentally, it was on this day that the funeral director was expected. For me, many things in the broken system needed to change, from the seemingly unregulated, invasive press to the bereavement telephone support line playing Bridge Over Troubled Water whilst waiting to speak to a coroner's agent. I wanted to fight for these changes, to protect future families from going through what we did, but I was already exhausted from the traumatic grief. I knew that I couldn't take things forward alone. I therefore focused on the Suicide Prevention Project. We have a stronger voice together and have been able to network widely, creating many projects along the way. Knowing that something will change, may change, or that we are listened to is of huge help. Nothing can ever take away the pain, and it is horrific to know of many others that are suffering or have suffered. Whilst this hurts, the peer support you get from those who get it and the hope that a broken system can be fixed makes involvement worthwhile. And my second reading is from a volunteer called Debbie, who's local to Leeds. And Debbie's got experience of suicide ideation and having made previous attempts on their own life. So good afternoon, everyone. My name is Debbie, one of the volunteers on the co-production project, and I have lived experience of suicidal ideation and multiple attempts to take my own life. Unfortunately, I've struggled to access any meaningful support from the NHS services over the years until recently, all of which stems from a self-referral I made during the height of crisis. To feel suicidal and truly believe you offer nothing to the world, even to your family and friends, is the loneliest place I've ever known. But then to be made to feel invisible, broken and worthless for having the feelings, or to not have one's pain believed and empathized with, is quite simply utterly soul-destroying. Being a part of the co-production project has been a healing experience. At all stages of my work on the project, my lived experiences have been listened to, validated, and incorporated into the ideas and delivery of the projects we have created. I've finally been made to feel like the expert in my own suffering, and that what I have to say about my experiences counts for something. Sharing my experiences has helped to create all of the projects you might be familiar with. One highlight for me was helping to shape the videos we created for frontline staff on preventing suicide. I was able to read out a message to staff that came directly from my heart in an attempt to use my story to create change. I shared what I hope are helpful messages on how to better support those in crisis, to raise awareness of how my experiences have negatively impacted me and to try and ensure mistakes are not repeated with others in the future. This project would not exist without the lived experiences of all the volunteers that have given up considerable time and effort to be part of this opportunity. We've been united from the start for our desire for change and knowledge that current systems are not fit for purpose, and everything we have worked on since day one has been geared towards raising awareness of this, reflecting upon what we can impact and taking action to create meaningful change. Being a part of this project has given me hope, and it has enabled me to make tangible change, knowing that projects I have worked on through this platform have already had such a positive impact brings me a sense of relief and gratitude like nothing else I have ever experienced. To have always felt like I will never achieve or amount to anything, it has been incredibly heartwarming to feel I finally have a purpose. So thank you for listening to those stories from those volunteers, and I hope that shows you just some of the time and dedication that our team of volunteers have put into this project. And I think something that I've learned is that all over West Yorkshire there's a huge appetite amongst community members to share their stories and to be involved in conversations like this one. People want to be part of that systems change. We're a project whose funding is going to run out in March, so after 2 years we've just got going and it feels like it's possibly going to end. So I hope that this pilot project makes a case for investing in some of that lived experience work, championing those voices, and for co-production as a method of making that change happen. So the last thing from us now, I'm going to hand over to Alison, one of our volunteers, and Alison's going to share her mental health journey with you.
Can everyone hear okay? Okay, so good afternoon. My name is Alison. I first began my volunteering with Arlie at Leeds Mind and the Suicide Prevention Initiative back in September 2022. Just to give you a wee bit of context about myself and my journey, I was a psychology university lecturer. Sorry, I was a university lecturer in psychology, a module leader in psychology, a one-to-one talking therapist, a person-centred life coach, until I wasn't. I have complex post-traumatic stress disorder. I struggled to accept it, I fought against it, and in my mind, I'd fallen from grace. I was none of those things anymore, not of any value. Sorry. I didn't know who I was anymore. The loss of identity, sense of belonging. I was just lost in a huge, dark, encircling vastness with no respite. Over 2 different surgeries, because I had to move, 2 of my GPs had referred me to Folly Hall over a period of those years. IAPT, now known as Talking Therapies, core team, a few times, and each time it was literally just like a box expedition. And I was handed leaflets, signposted. I was told I wasn't suitable for the services and told me to go to the Women's Centre and another place over in Dewsbury. At the time, I could barely get out of bed, let alone anything else. Basically telling me all the things to do. Telling me all of the things that I told them that I could not and would not be able to do for all the reasons that I told them. I informed each person what I needed. This was not listened to and it was not taken on board. I struggled massively over the years, and how I'm still standing here before you. Sorry, I thought I was going to be stood up. It's how I envisioned it. And how I'm able to be before you is nothing short of a miracle. There are many experiences and factual information regarding ways in which I have fallen through the mental health NHS net and like the reasons why, but time-wise prevents me from going into that. So I am here before you with lived experience of suicide within my professional and personal life. My best friend who I grew up with, my first boss when I first moved to Huddersfield, both took their own life. My biological mother's suicide attempts, students and clients who had suicidal ideation, and then my own personal experience. I have a wealth of educational knowledge, experience, personal and professional knowledge, and first-hand experience of how challenging, soul-destroying and crushing it has been in trying to access the healthcare services. I was not heard, I was not seen. I was not a human being that stood before them. I was a number, just a tick box. There was nothing person-centred at all. The way in which I felt about myself, the feelings of loss, despair, the shame and guilt that I carried around was magnified in such a painful way by the way in which the so-called healthcare system handled me in my situation. All of that said, through volunteering with the Suicide Prevention Initiative as a volunteer has been so liberating and powerful, and empowering and powerful, which may sound unusual words when discussing suicide and suicide prevention. Yet what we are doing is helping people to feel heard and seen, to feel valued, to be valued and feel valued. I know personally that I have started to find my voice again, hence being here, find my voice again through projects like this. Through utilising lived life experiences, you gain real and raw insight into the struggles and the stigma surrounding mental health challenges, with the real aim of changing systems and procedures within the mental health arena. This is why it's so important to involve experts such as ourselves and that you've heard today, and believe that it is the way forward. This project has given the voice to so many that have been silenced, ones who can make a difference, have made a difference with partnerships such as these. And I hope and pray that you do take on board things that you've heard in any podcasts and any videos that you may see. And thank you for the time that you've given.
Thank you, Alison. That was incredibly powerful. And thank you, Ali, for the stories you brought along. And thank you to all three of you for coming. Are there any questions or reflections that anybody wants to offer in response? Tracy and then Fiona.
I just want to say thank you so much for that. It was very moving, but also a really great example that this is not just one special story, that there are so many people going through what you went through. And it is your superpower, your lived experience, because nobody can tackle a system as you are doing without having had that lived experience. So thank you. But I'd also like to encourage the project to apply for the Mayor's Community Safety Fund, which is the proceeds of crime money. This year we've taken from criminals £1 million, and it's up to 8,000. That may not be enough for your project, but I just encourage you to apply. And also around suicide prevention, whilst it's not my space per se, as the Police and Crime Commissioner, it is something I'm working with West Yorkshire Police, because of course the officers themselves see this in their workplace, and they have trauma from it, and there's a number of interventions, and I'm very happy to share that, Chair, with you in more detail around suicide prevention, but it feels like there's a space where maybe we can be helpful.
Thank you, Tracy. Fiona?
Thank you. I wanted to make a personal reflection and then a comment about the fact your contract's about to end. So before I was a full-time counsellor, I was the Chief Executive of Leeds Survivor-Led Crisis Service, and I set up the Leeds Suicide Bereavement Service with Leeds Mind. It was a joint project at the beginning. Of all the services that I set up, the Suicide Bereavement Service has a really special place in my heart because I set it up really out of personal experience of having been suicidal and being bereaved by suicide a number of times, actually. Having worked in mental health crisis services and been in the survivor movement for a long time. So I'd like to thank you for coming here and for the generosity of spirit that it takes to share your personal experience. Having led a survivor-led crisis service, I know the cost it takes to use your own experience in your daily work, although it's also very empowering, and it's great to think you can make services better for other people. I suppose the wider reflection I wanted to make from Kim's point before about the vulnerability of the voluntary sector is that what's really worrying about the current situation I find from the situation I'm in now as a senior counsellor is that the financial crisis we're in, I worry is forcing us to make decisions that we know are bad decisions. So in the world I'm in now, we're having to cut services in Leeds that we know keep children out of care, and it's devastating. We have no choice because we will go bankrupt if we don't make the cuts we need to make to balance the budget, but it feels like a moral injury to me, a term that I know is used quite a lot in the NHS when you feel like you're doing a bad job because you're having to make decisions that you know are not great decisions. I suppose in this arena, I just wanted to stress to everyone here, these are the sort of services that are not statutory that I think are really vulnerable in the crisis that we're in. However, services around both suicide prevention and services that support people who are bereaved by suicide are so cost effective. They're cost effective in human terms, most importantly. You know, we know people that are bereaved by suicide are at much higher risk of, you know, ending our own lives. But also, we know how much suicide costs financially, which is a horror. I don't mean that to sound in any way disrespectful or distasteful, but it's a reality. You know, it has been costed. I think it's 1.7 million. Some health economist has worked that out. So, and I think the analogy of a bomb going off is really accurate in terms of the devastation of suicide bereavement is for the people in that person's life. You know, the lost hours that people can't work because they're bereaved, the costs involved in the coronial aspects of a suicide death. So these are the kind of services that we have to protect, because, you know, the savings that you make in both human terms and financial terms are massive. So yeah, I just want to say thank you for coming here and thank you for your personal testimony.
Thank you. Fatima?
Hiya, my name's Fatima Khanshah. I'm the West Yorkshire Inclusivity Champion. Firstly, I just want to applaud your courage, all of you, for coming here and talking about your lived experience. As someone who many people in this room will tell you is not afraid of saying what she thinks or feels, being impacted by suicide myself, I could never talk about it as articulately as you have. So, you know, it's really courageous what you've done today. My question is, as the inclusivity champion, part of my role is to convene spaces to facilitate conversations about issues that people sometimes don't always talk about but are really important. You mentioned stigma. I know from my own lived experience there is a massive issue in certain communities about suicide, about living with suicide, about the impact of suicide, about having conversations with people that may be at risk of suicide. I'd like to offer an opportunity to have a conversation to see what my role can do to support you, in addition to what Mayor Brabin's just said. And I'd also like to support what Councillor Venner's just said as well about the importance of your services. But I do think there is an important point that we can't lose sight of, which is supporting people living with the aftermath of a suicidal experience is everyone's business. And you talked a lot about the experience of services, but also people that manage employees all across society right now. And I think we're doing some great work on supporting people with lived experience, but I also think we need to support people that are managing the aftermath as well in a much more impactful and nuanced and emotionally intelligent way. So I'd like to make that offer to you to maybe have a conversation outside if you're up for it.
Thank you. I'll go to Teresa next.
Thank you. My name is Therese Patton. I'm the Chief Executive of Bradford District Care Trust, which is the mental health and community trust in Bradford. First of all, I want to thank you for sharing all of the stories. It just brings home the job that we try to do every day, often not very well, but what brings us to work, and the courage you showed in sharing your story with us is really powerful and impactful. I'm just looking at the recommendations, and they feel a little weak, maybe not the word, actually, when we look at what the power of this group is. And what I want to offer to you on behalf of the Mental Health Collaborative, which I'm sure you're working with, I can see Daryl there, is we need to take responsibility and support alongside you to actually look at these recommendations, to make them stronger, to make them bolder, to ask for more, might I say. And I think, Rob and Cathy, that we then come back with a real plan of how we can actually mainstream this, because Kim and I have been talking about parity of esteem. We're talking about one of the 10 big ambitions about really supporting mental health and community services in a sustainable way. So I think we've got work to do, if I may, to take these recommendations away and make them a little bolder with the support of the collaborative and come back with some stronger asks.
Thank you. I'll bring Cathy in and then I'll move on to the paper. Yeah.
Great. Thank you very much for coming today and taking the time to come and join us, and for sharing experiences yourself and of others. It is incredibly powerful, and it helps us all as leaders just to stop and listen and take it in. What you also make a case for in whatever service we might be looking at is valuing lived experience, because you can help us design services or change services for the better. And I'm really grateful to you for that. This is when I want to bring in my colleague Karen Coleman very briefly, just to talk about the fact this is what we try and do all the time, is bring lived experience in. And maybe you could just, Karen, really briefly talk about that, because I want to back up what you've just shared and remind everyone in the room that valuing lived experience is an important thing as we deliver services and redesign them as well. So thank you.
Thank you, Cathy. Can you hear me okay? Yeah, afternoon everybody, I'm Karen Coleman, working communications and engagement for the partnership. I think lived an experience and, I think we all had a bit of a tear in our eye, didn't we? And sadly, I think we all know somebody who's lost their life to suicide, and it brings that home, doesn't it, especially if you're a family member. I think what we've done in West Yorkshire on some of our big campaigns, and they're award-winning campaigns, and that's not because we're super clever communication people, that's because we've involved people right from the start in what you were talking about, which was co-production. So if you're looking at the check-in with your staff campaign, that was award-winning in that talk to NHS Council, Health Watch voluntary organisations and people who'd been impacted by suicide, and how they could help one another in the workplace, just to look out for the signs, to do the 20-minute zero suicide training online, things like that. And then we also did another shortlisted campaign, which was Check In With Your Mate, which is a great campaign, and you might have seen that across some of our stadiums and on our buses as well, and in some of our big spaces, and that's to remind each other to look after our men or men friends in our lives. So we always try to use co-production, and I think that should always be the starting point for any communications we do. So do keep talking, and I think it's whatever your experience, because I think we've all got something to learn, haven't we? So thank you.
Thank you. Rob, you wanted to comment briefly?
Yeah, just two reflections really. So the first is that the biggest killer of young men in West Yorkshire is bound to have an impact on a lot of people, including a lot of people in this room. And I think we've heard from people who said, I've been bereaved by suicide. I've been bereaved by suicide myself. Many people in the room will, and they won't say, or don't need to, or don't feel like they have to at this point. But we should recognise that there'll be people in the room and people watching who will be affected by what you've talked about. And, just to reinforce that there is hope, there is help, and there is support. And, if people are triggered in the room or outside watching this, then, go onto the website. You can get immediate access to support if you are impacted as a bereaved person or someone with suicidal ideation. But we should just hold that other reflection that actually this isn't a minority sport, unfortunately. It's something that many people in the room will have been directly impacted by. And we should just, if we start to realise that consciously, then we start to pick up Therese's point about, how do we make this much more mainstream?
Thank you, Rob. So reducing suicides is one of our 10 big ambitions, and I'll ask welcome Daryl, Richard and Vicky now, and ask you to introduce the paper on this. And perhaps, if you want to comment at the end of this, Ali and colleagues, you'd be very welcome to. Okay, thank you.
Thank you. Should we each introduce ourselves? So I'm Richard James. I'm the lead for suicide prevention at the West Yorkshire Health and Care Partnership and an acting consultant in public health.
Hi, I'm Vicky Spencer-Hughes. I'm a consultant in public health at Calderdale Council.
Hi, I'm Darryl Thompson.
You can't see the light.
Oh, I can't see the light.
Yeah.
I'm not doing well with technology. I'm Chief Nurse and Director of Quality and Professions at Swift, and not good with microphones.
So before we begin, I'll just kind of echo what you've said actually, Rob, in that obviously we have been discussing, and this item does discuss suicide, and I know a lot of us have been affected by that. And just to say, if at any stage this is proving very difficult, then please do feel free to step outside or to take a break. And again, as you said, Rob, there's a lot of support available across West Yorkshire. And if anything that's said today has affected you, or you have been bereaved by suicide or are feeling suicidal, then please do take a look at the website, because all the support that's available is listed there. And finally, just to say before we start, I know it can be difficult to know how to talk about suicide, but the words we choose do matter. And we really don't want the worry of saying the wrong thing to stop the right conversations from happening. So we do have a Creating Hope Through Language guide on the website as well, if that's something anyone was worried about. So in terms of what we'll cover today, I know there was a lot in the report, so I'm not going to go through everything, just going to touch on a few key areas and add a little bit more context where I think it might be helpful. So I'll just touch on the data and the rates. I'll touch a bit about what our suicide prevention work looks like. We'll hear from where most of the work happens, which is with PLACE and with partners, and in the voluntary and community sector and in communities. We'll then talk a bit about how we've been adding value through system working as a partnership before moving on to some of those risks to delivery and the recommendations and the asks that we've got to the board. So I think we've already discussed this a lot, but before I go on to talk about numbers and rates, I just want to remember what sits behind every one of those numbers. And every life that's lost by suicide is a tragedy, and every life lost carries with it its own story, and every life lost has such a massive impact on family, on friends, on workplaces, communities, and more. And in West Yorkshire in 2021, 281 preventable deaths were registered as being suicides. Now, we also look at suicide rates, and you would have seen a couple of graphs in the paper. The first looked at the rates in West Yorkshire, and it showed that they've been increasing over the last 5 years up to 2021, which is the point at which we most recently have data. And it also showed that rates in West Yorkshire were higher than they were across the country as an average. The second graph compared rates across each of our 5 places, and I won't go through all of them because it's in the paper, but the takeaway was that there is variation across our patch. So there were 3 kind of reasons I wanted to bring up those graphs now. And firstly, while these numbers need to be smaller, and while every single suicide does carry with it that massive impact, from a sort of statistical point of view, we're always careful when we're looking at smaller numbers to read too much into small variation. Secondly, we've got to be careful that we're comparing like for like, and we're not always doing that in these figures. The data's around deaths registered following a coroner's inquest as a verdict of suicide, and there's variation in how long it takes to complete those inquests, in the way in which different verdicts might be given, as well as across time in the legislation around those verdicts. Those caveats said, I think we do have evidence to say that the rates have been higher in West Yorkshire, and we do have evidence to say that there's variation across our patch. We need to understand this, and to do that, we have to understand our populations. And the first thing, as with so many health outcomes, and as we heard from Sarah and Sahel, is that deprivation is linked to suicide rates, and that can certainly explain some of the variation that we see. But the picture is far more complex, and as we'll go on to talk about, a huge number of different factors linked to suicide risk. And I think the reason for saying this is that when we look at these graphs, it's really tempting to see this as a sort of performance metric for an individual service, for mental health services, or for anything else, or to say, London's got the lowest rates, let's copy what's going on in London. But it's just not that simple, unfortunately. And what we have to do is understand our own populations, who they are, what experiences they're having, what's sitting behind that suicide rate. And that's how we as a system can achieve that ambition of 0 suicides. And that's what I'm going to talk about, what sits behind the suicide risk, and accordingly, what sits behind our suicide prevention activity. So as a programme in West Yorkshire, we sit within the Improving Population Health team, and we take a population health approach. And there are 4 areas I'll focus on. We talk about the population groups at greater risk, those experiences that happen to people that further increase that risk, those support that's available, be it in communities, be it health and care services, that reduces that risk. And finally, we talk about how people are accessing the means to suicide and how we can intervene, even at the final crisis point. So before I go into too much detail, I just wanted to mention and to touch on some of the data. And in the paper, I listed a huge range of sources of data we have, some of it more strategic for proactive work, especially around our suicide audits being conducted at place, some of it more reactive and sort of operative. Much of that goes for our suspected suicide surveillance system to enable us to respond in real time. But the thing I wanted to mention was that our insights and our intelligence, they don't just come from numbers and spreadsheets. They come from people, they come from co-production work, they come from lived experience, and they come from partnership working and us all coming together and sharing our insights. So I'll briefly mention something about those 4 areas and just give a couple of examples of the work that's going on, just to give a bit of a flavour. It's by no means a comprehensive list. So in terms of population groups, there are some larger groups with moderately elevated risk, like men, who account for 2 in every 3 suicides. And we've been addressing risk through things like wide-reaching campaigns to raise awareness, as Karen mentioned, the Check In With Your Mate campaign. Other populations are smaller, but with a much higher risk, such as gypsy and traveller populations, where the risk of suicide is 6 times higher than in the general population. And Leeds Gate have been doing trailblazing work there to do higher intensity interventions, that kind of proportionate universalism, including one-to-one support. Finally, there are some groups of increased risk, but where we have massively increased ability to influence, like our health and care workforce. And we've been doing whole population interventions there, like our check-in campaign, as well as more targeted interventions, looking at reducing gendered inequalities in access to our West Yorkshire Wellbeing Hub through commission work through Men in Health. In terms of those risk factors, those experiences, those events that happen to people, the recent Leeds suicide audit, which is the most recent suicide audit to be published at places, found 26 different risk factors with an average of 5 to 6 associated with each suicide. I can't go through all of them now, but I can just touch on a couple, and one of them, I think one of the key ones, is bereavement by suicide, as was mentioned, being a massive risk factor for suicide. And we have the fantastic Leeds Mind Suicide Bereavement Service, as well as a comprehensive postvention system linking up with West Yorkshire Police and a coordinator in there to make sure that people do get the support that they need. Other risk factors include things like financial exclusion, unemployment, long-term conditions, chronic pain, or access with the criminal justice system. And we have some cross-sector interventions, like training that we commission through Papyrus to make sure people who are coming into contact with people who are going through difficulties are trained in suicide prevention, as well as some sector-specific interventions, like commission work specific to the criminal justice system. In terms of that support to reduce risk, as I said earlier, most of this isn't health and care services. It's communities, it's families, it's friends, it's workplaces. And we've got our Suicide Prevention Champions campaign that I'll mention, and I mentioned in the paper, that's aiming to make it easier for people to have conversations, to tackle stigma, and to signpost to what support's available. And our website is a fantastic place for people to use in doing that signposting. We also have responsibilities as anchor institutions to ensure our own workplaces are supportive. And a great example of that is the in-house suicide prevention training that we're putting together as an ICB for all staff within the ICB. And further, we've got a responsibility to ensure frontline staff are comfortable having the discussions, assessing risk. And again, we're working on training with groups like social prescriber link workers, as well as ensuring we're integrating all the findings that come from the co-production work and using those fantastic resources that have been put together. I won't talk as much about reducing access to means, other than to say we have our suspected suicide surveillance system, and we bring partners together to share data in real time to address issues like suicide clusters, like frequently used locations, like changing trends as and when they happen. So I've talked for quite a long time, and while I'll mention a little bit more about our West Yorkshire programme later, this isn't where most suicide prevention happens. We need much longer to talk about everything that's going on because there's so much work, much of it going on in the voluntary and community sector. But we're going to get a bit of a flavour, and I'm really glad to be joined by Vicky and Daryl to talk a little bit about the work going on at Place and Provider.
Thanks, Richard. So on the slides that you got in the pack, it's down as local authority, but I just want to say the work we're doing in Calderdale, and I imagine it is elsewhere, is actually under our Health and Wellbeing Board, recognising the importance of tackling suicide. We've got 4 life courses that we look at under the Health and Wellbeing Board. In living and working well, the priority is good emotional health and well-being and reducing suicides. So I guess that shows how important it is that we recognise it, that it's a partnership and it's everyone's issue, but also that while all the services we've talked about earlier are really important, it's also that wider context of trying to ensure people don't get to the point that they feel that ending their life is an option. So recognising the impact of having good work, having enough money, of meeting cost of living, all of those other elements are important. So again, it's using the data to identify those people who are at higher risk and high-risk groups, and work with colleagues in the NHS around improving mental health and making sure that services fit for people and that it's easier for people to get the help that they need. Richard's touched on reducing access to the means of suicide. Unfortunately, in Calderdale, we have a high-risk public location that's strongly associated with a place that people go to end their lives. And so that's a long-term, complicated piece of work with partners that we need to do to try and change that situation. I guess there's different ways of tackling it. There's the physical barriers and those engineering, heritage and capital challenges, but there's the sense of association with the place and how we can tackle that through the work that's already happening to shape town centres. It's how you work with community to give people a sense of hope and to change that. And another really complex thing, I think, is that when someone dies, often family and friends want to grieve and sometimes physically demonstrate their grief by leaving things in a public place. And there is, you know, concern that that can trigger things for other people. And so it's a very sensitive issue that we're still trying to work through. I don't think we've looked and talked to other people. I don't think anyone's found a robust solution yet, but that's something that we really want to involve people with lived experience. We've had some preliminary conversations, but that's just an example of some of the things that we're thinking about. Other elements, that providing better support for those bereaved by suicide, we've already heard how really, really important it is. And it's fantastic offered through West Yorkshire. I think recognising Calderdale's got some quite remote places, it's also ensuring that it's in the right places for everyone so that everyone can access it. Other elements in our plan, communications and engagement, again, it needs to be with people so that we get the right messages to the right people about how to find help, how to have hope, but also a conversation about how do we tackle this together and let people know that it does matter. Someone mentioned the very irresponsible media of reporting. I think it's really hard to tackle, harder and harder with social media because I think newspapers are more responsible. So again, that's a thing we need to think about collectively and all contribute to responding to things in a kind way. Another element of our plan is, I'm sure it is with everyone's, it's using that data, that research and that monitoring to understand what's going on and how effective we're being, but who we need to reach and how we best do that. And it's not just data, as Richard said, as in hard data, it's lived experience and really understanding from people what will work. And again, it's how we work collectively together effectively and doing things once, because we've got not enough resources, but I think sharing through West Yorkshire, the website, the campaigns is incredibly helpful, but then we also need to target it in a way that works within Calderdale. So I think that's one local authority perspective, just a taste of the things that we're thinking about.
I've had more success with the microphone this time. I guess so. So in my role, I'm one of the co-senior responsible owners for the programme, and I work alongside. It was 4 colleagues until yesterday. One of our colleagues has unfortunately had to step down, but that's with another chief nurse from one of our mental health providers, Nicholas Anderson at Leeds and York, and also with Rebecca from a public health focus. So we seek to get all views. So I guess it's from a secondary mental health services point of view. So I'm here representing South West Yorkshire and Leeds and York and Bradford District Care. So we see and support people who are suicidal or who've been bereaved by suicide when that is linked to significant mental health problems or at a particular point of crisis. And I guess risk assessment and risk management is always going to be a key part of our role at that time. Part of how we work together as providers across the organisation is to seek opportunities for learning. What can we share between ourselves, and also what can we share more broadly outside of West Yorkshire when we, for example, come across new methods, when we become concerns about clusters or contagion, what can we share for greater learning? So we have the Secondary Mental Health Services Suicide Prevention Group, so that's got representation from all of the providers with a very clear and specific focus around suicide prevention. It's also where the providers consider and link into all the work at place. So Richard's talked about the significant amount of work that's at place, and so it's how can we make sure that we are connected to that, both with regards to what we can contribute as providers, but also what we can learn as providers with regards to the populations that we serve. Just thinking through the other parts of it, the suicide surveillance in particular is a key aspect of how we seek to be vigilant around emerging trends, but also that signposting, and in particular signposting to our colleagues around postvention, knowing that being bereaved by suicide is a suicide risk in itself. So yes, the summary for us is particularly how we can focus as mental health providers. Clearly we will not be seeing all of the people who are suicidal, but we will be seeing a significant number of people who are at that highest risk place, and what can we do at that point to give our best chance of a positive intervention?
Thank you. And there's, yeah, a huge amount of great work going on across West Yorkshire, and I've tried to start a list in the paper, but you could spend, the paper could have been 100 more pages long if I were trying to include everything that's going on. But I guess the point is, in West Yorkshire, we've worked really hard in producing the strategy to make sure it's not just based on all the different types of intelligence we have, but it's embedded in that ecosystem of what work is going on elsewhere. And we've tried to make sure we're not duplicating, we're just adding value where we can. And that approach is about sharing good practice, about influencing the wider system, events like today, about increasing awareness around suicide prevention, and only when it makes sense to do so, about doing things once at a West Yorkshire footprint. And there's a whole suite of metrics included in the paper looking at the impact of our strategy in achieving that ambition. But what I wanted to just feed back now were 4 quotes that I think probably say more than those tables or graphs could. So in terms of the impact of projects on our workforce, after possibly the bleakest period of my life so far, I genuinely attribute my survival to the training my team and I undertook and the resources available to me from the partnership. Around the impact on service users, we have nobody to help us really, and we never had. I don't know what I would have done without Leeds Gate all of these years. I'm so happy you are now coming to my place because I need some help and support again. I'm worried about my whole family. We aren't coping. Thank you so much. I can see a future if we stick at this plan. From one of our other local authority partners, we know from our suicide audits and national data that those bereaved by suicide are at increased risk of suicide themselves. The funding used to commission the Suicide Bereavement Service is a key example of using data to inform commissioning and addressing gaps. We have people who have been supported by the service and are now able to speak about their grief and the person who died. This is early intervention and prevention for the next generation. Some of the benefits of this work will not be seen for years to come. And from colleagues in the voluntary and community sector, the service can only do the great work it does because of the support of the partnership. So I just want to talk now about some of the risks to delivery, and I'll start with the positives in that we have the partnership ambition, we have that agreement that suicide is preventable, and we have a partnership strategy and strategies elsewhere in the system that I think means we know where to act, we know what to do, and increasingly we know how to do it. But we're facing that increased demand with a reduced ability to meet that demand. And I mentioned it in the paper, so I won't go through it all now, but across all those 4 areas that I mentioned, we're seeing potential for the demand for our services and the potential risks around suicide increase. And on top of that, the improvements we've made to our data systems mean we're much better at being able to recognise that increased demand. And as far as that reduced ability to meet the demand goes, across our West Yorkshire strategy, and I know there are similar challenges at place, 9 out of the 12 areas that we currently deliver around use non-recurrent wave funding that came in 4 waves from NHS England but has now ceased without any alternative funding coming through. So we're currently left in a position where a lot of the work that we've commissioned, including the fantastic co-production work through Leeds Mind, we're in a position where we don't have protected budget for suicide prevention where we can refund that. So in terms of what we've been doing, we've been making the most of our existing resources. We've done a lot of campaigns and a lot of networks using the existing resources in the partnership. And in fact, using colleagues in the Calderdale Public Health team have done fantastic work putting together the resources for our Suicide Prevention Champion campaign, which was developed in-house. We've been generating additional capacity where we can through proactive grant funding, through training placements. I myself am here on a training placement, and through the Suicide Prevention Fellowships, again with the 3rd round of the fellowships just having launched. But the current dedicated suicide prevention capacity is stretched, and it's soon to be reduced in January, which does make it tricky to continue to deliver and to continue to expand as we'd like to in the strategy. We've been attempting to mainstream successful projects and work that's been piloted successfully, but the financial climate has made that challenging. We have been fortunate with some contracts, like the work through Leeds Gate and our West Yorkshire Police Coordinator role, which sits at the heart of our suspected suicide surveillance system, as well as our post-vention work, being funded in the short term while we have those conversations about mainstreaming. But some areas, like our co-production contract, like our contract with Men's Health, reducing gender inequalities and access to existing support services, like our Practice Plus contract in the criminal justice system, and like our contract with Papyrus, providing training all across the system. There are areas that are at risk of ceasing in the near future because we don't have that recurrent funding. So the asks to boards were firstly to recognise the work going on across the system, not just what I've put in the report and what I've said today, but the work that will be going on across all of your organisations. To let us know what we can do differently to better support you, but also asks to you as leaders. First, to make suicide prevention everyone's business. Second, to mainstream successful suicide prevention activity. And third, to consider how we can fund some things to do once at a West Yorkshire footprint. And I'll just give a tiny bit of information about what I mean by those three asks. So around the making suicide prevention everyone's business, I think a great way to do that is to sign up and become a suicide prevention champion. It's a way you can do a little bit of training, about 20 minutes of training. It's a chance to sign up to newsletters and to networks locally and at a West Yorkshire level that are a brilliant follow-up from today's talk. But it's also a chance for you as leaders to make a pledge and to think, where do I fit in? Where are my responsibilities? What can I do differently? What can my service do differently? So we aim to have 281 champions by the end of the year, one for each person who lost their life to suicide in 2021. I think we're about 15 off that at the minute. So it would be fantastic if we could reach that target after partnership board today. Secondly, that mainstreaming, and it is similar, but there needs to be ownership by everyone around suicide prevention, not just in terms of what's the statutory role, but in terms of what's your role in a system. What's your ability to support your workforce? How are you meeting need rather than service specs? Or if need cannot be met, how are we coming together as partners, as a partnership, to provide integrated and joined up care that catches people who are currently falling through the gaps? And that means we need partners to be proactive in making the most of all the resources that we've got across the system. And where projects have been piloted, we need partners to be proactive in embedding those and in mainstreaming them. And finally, that doing things once across a West Yorkshire footprint. And the costs of the contracts that we've spoken about, the co-production contract, the Men in Health contract, they're all relatively small, about £50,000 a year. And the financial impact is not a nice way of talking about it, as you said earlier, that figure from the Department of Health of 1.67 million doesn't compare to the cost, as well as all the other non-financial costs that we've mentioned. So that was the final ask, was to think how we can come together to fund work that fits within our own remit as an ambitious suicide prevention programme within an ambitious health and care partnership. Thank you.
Thank you very much. Are there questions or comments? Fiona and then Susan.
Thank you. I just had a couple of comments. So you mentioned the lead suicide audit. Although men remain at significantly higher risk, one of the really striking new elements of this suicide audit was significantly more women having ended their lives, and also up to this point it's tended to be men at middle age, and there was people in older age categories being at higher risk. We've been doing suicide audits in Leeds since 2008, so the first one covered 2008, 9 and 10, and then they've all been in 3 years, so the last one's 2019, 20 to 21. There's a couple of risk factors which have been really consistent across that period. One of the most striking ones was around debt and finance, and it was really striking when we went into austerity, that comparing the audit from 8, 9 and 10 to 11, 12 and 13, and then 14, 15 and 16, the increased trajectory around people dying, ending their own lives with finance, debt, workloadness being issues. Another issue that's been really consistent but was really striking in this latest audit was people being single being a really high risk, particularly people being separated, divorced. That's really stark in this latest audit, but it's been a risk factor all the way through. And I think, again, this is a sort of funding that could be seen as fluffy, but actually projects we can fund around loneliness and isolation can literally be life-saving, because loneliness and isolation just it's heartbreaking. It just really shines out isn't the right word, because that's normally has positive connotations, but it's really stark in all the audits, the impact of loneliness and isolation. With regard to the media, I mean, we're in a really different place now with social media, but many years ago, possibly as much as 15 years ago, we did some work in Leeds with the National Union of Journalists, because the Irish government did it first. The Irish government and the NUJ produced some guidance around appropriate reporting of suicide, and then somebody who at the time was working in comms at Leeds Council was also quite prominent in the NUJ, and so we did a piece of work with the NUJ about media guidelines around suicide. So they may be really amenable to doing something again. Although this was before social media, it does feel like we're in a very different landscape now, but they were a good partner in the past, so I just thought I'd mention that. Thank you.
Thank you. I've got 3 or 4 other people who want to comment, and then I'm aware we're eating into the time for the last item. So, Susan.
Yes, thank you. So, obviously, any suicide really is a failure of our system, isn't it, to intervene earlier, really? I imagine that's quite a simplistic way, but how I see it is that actually if somebody had known earlier, or if somebody had reached out to that person earlier, we could have prevented this. So the fact that it's going up would suggest that we're getting worse at this, actually, which is a concern, because obviously we've already heard about early help and prevention being really significant in actually preventing harm later down the road, and this is just another instance of it. You had some stats in here around inequalities. Obviously, going back to the other item that we had, you've some ethnicity figures in here. I know in Bradford we commission work specifically around to organisations that support people who are of an ethnic minority with this scope. But I think it's probably underdeveloped from other organisations possibly. And just a few comments on that. And then finally, I mean, obviously this is a bit of a theme now, isn't it, with early help and prevention. I just wondered, Rob, I would love to have a conversation with the Permanent Secretary of the Department of Health, because it seems to me that they can't be having the same conversations that we're having at local level, not to invest in some of the stuff upstream and just to focus on accident and emergency, A&E, waiting time. So I would genuinely love to have a conversation, and it could be behind closed doors, with the Department of Health civil servants as to what their rationale is for how they think the country's going to run. Because if we continue, shrinking the money available for early help and prevention, then the budgets for the guys in the acute sector are just going to get higher and higher and higher, and that there's never going to be enough money. So I genuinely don't understand what their strategy is, and I'd like to understand their strategy. Could they come to a future meeting of the West Yorkshire Health and Care Partnership? Could we invite them? Thank you.
Thanks, Susan. Andrew?
Thank you. So I'm Andrew Gold. I'm the chair of Airedale NHS Foundation Trust. First of all, some feedback. I couldn't hear actually much of the presentation from Vicky and Richard. So whether you covered this, from Vicky and Daryl, so apologies if you already covered this, but when I read the paper, a lot of it seemed centric around our conurbations. So here at Airedale Hospital, we serve a 700 mile square rural community. And I wanted to understand how much this work had actually looked at the potential differences associated with that, and differences both in terms of the inherent risk of suicide and, more important, a different ask and a reach to be able to make a difference and therefore achieve the partnership ambition across all parts, not just the examples that were cited in the paper, which were all conurbations, Leeds, Coaldale and Kirklees.
Thank you. Kim? And then I'll bring Rob in after Kim.
Thanks. I used to be one of the SROs for the suicide programme, so really passionate about this subject, and so good to hear the progress that's been made. I guess I wanted to do a bit of a rallying call. This is one of our 10 big ambitions, and we're talking in this paper about relatively small sums. And I think one of the problems is, and in my experience of working on this programme, is it has to be everybody's business, absolutely. But the trouble is, when things are everybody's business, they become nobody's business. And we're not taking that action and accountability to make it happen. So the very, very teeny tiny core team of people working on this at West Yorkshire level is incredibly valuable in the work that it does. But then, like Susan says, the resource that's available, the majority of the money is in public health. And of course, we know that the money for public health has historically been decimated and continues to be. So I suppose we had a development session earlier. So what is our appetite to do something differently in this space and come together to address this? Because absolutely supporting Therese's comments, I think we take it away and do some work on coming back around the recommendations. And then the last thing I guess I wanted to end on is, you know, we've got a lot of chief execs leaders in this room. Is there any reason why we couldn't all put up our, you know, I've got my own organisation. Why couldn't we all put up our hand and say we're going to have a big ambition that we're going to train 50%, 100% of our staff in suicide prevention as mandatory training in the next year? Like, why can't we do that? That's the kind of ambition we should be having in West Yorkshire.
Thank you, Kim. Rob.
Yeah, so thanks for the paper and for the recognition that the majority of people who die by suicide aren't in touch with mental health services, which is why it's everyone's business to make sure that we're creating safe contexts and environments. And I think to Councillor Hinchcliffe's reflections around are we getting worse at this, actually what happens in times of financial distress is the conditions become such that more people are likely to die by suicide. That's the evidence. So we need to see it as more of a priority, I would say, is the way I would look at it. I'll come back to her offer to the Permanent Secretary of the Department of Health and Social Care in a moment. I think the thing that I wanted to ask, really, and I know we haven't got much time, so we could take this away, is that, you know, that 28% of people who are in touch with mental health services, there is a national confidential inquiry into safety in mental health and suicide, and that's got 10 ways to improve safety. I've just got it on the screen now, I've just looked it up again. I didn't see much about how our providers are working collectively to make sure that those things are adopted and whether we're confident that all those things are being done, which I think when we started this programme was one of the big things we wanted to do. What's the best evidence possible, learning from Detroit and its zero suicide approach, which would allow us to reduce the risk for people who are in our mental health services, because over the years we've done a brilliant job actually of reducing the number of people who die by suicide as inpatients or upon discharge from mental health units. So not for answering now, but I think to take away. Does the Department of Health and Social Care understand? That's only a question that they can answer. What I can say is that in West Yorkshire we've got a hub with the Leeds hub with the Department for Health and Social Care, because they are based in West Yorkshire, and we do have the opportunity to talk policy with them, and they are interested in how we make sure that policy is effective and impactful. And I think we should extend the offer, really, to say, do you want to come to a development session or do you want to come here? And we can talk about early help, prevention and support.
Thank you. Thank you. So quite a few things to take back, if that's okay. I'm not sure we had the opportunity to pick up every point and comment as raised, but thank you very much for the paper. The sense we clearly want to endorse that, but there are numbers there, and I think a great challenge from Kim about some very practical things that perhaps we can look at building in as well. And thank you again. I hope you found the conversation helpful. Thank you. Okay, thank you. So our final item is I introduced Kate O'Connell and Michelle Stanley from Leeds Health and Care Academy. Did you want to say anything on this, Rob? I've got your name against this.
So Kate Sims is chairing the Regional People Board this afternoon. She'd normally introduce this, but this is something that was discussed at the People Board. There are a range of issues that are discussed each time the board meets in terms of good practice and where we might want to share practice and adopt practice. So I know that the fantastic health and wellbeing offer in Kirklees that Carol and her team support was one thing that was discussed previously. I think some of the work in Bradford that goes on has been picked up, and this was an opportunity to look at the work around inclusive recruitment and support in the Health and Care Academy in Leeds. Where I would think I'd particularly like to focus as a programme, as a partnership board, is how directive do we want to be towards the People Board in terms of asking for good practice to be adopted, and how voluntary do we want to make it. And I'm also interested in whether we think we've got the infrastructure in every place to adopt good practice on the people agenda. So that's my introduction and a bit of a challenge really as we get into this last session.
Thank you. So, first of all, thank you for being able to be part of this really powerful conversation today, because that's what this work is really all about. And I wanted to start by a bit of an introduction around the deep partnership in Leeds that has enabled this work to take place. So we've heard about the power of people's experiences, we've heard about the powers of communities, we've heard about the interrelationships between health, economy, environment, all of these things, that they're so connected that tackling them individually makes no sense. The power of those deep partnerships extends across our education providers, our employers, our third sector, our independent providers of care, people who are not paid carers, people who care for family members, people who care for themselves. It's about that whole community, that whole infrastructure of health and care. And that's really where we started this work around narrowing inequalities. So our workforce across health and social care in Leeds is about 60,000 people. They're the paid workforce. You extend that into volunteers and unpaid carers, you can double that easily and then some. So we're talking about a huge number of people who are actually our people. They're our workforce, but they are our population. They are our communities in Leeds. Their influence out in communities is huge. That peer influence, that peer support that they provide within their families, within their local groups, within their local networks is really powerful. So in Leeds, we've got a really clear ambition around narrowing health inequalities, and that inclusive approach is really at the heart of this work that we do. We wanted to take a fundamentally different approach, not just a project, not just a programme, but really changing the way our system works. And that takes time. So we've heard today about holding our nerve, and that has really struck a chord because that's what this work is about. We've taken a really clear approach collectively to defining impact. So being clear what all of our partners, all of our people who are involved in the co-creation and the co-development of this work mean by success. Do we know what success looks like? How are we going to test that? Are we all comfortable with the direction this goes? Because this work has to have focus. It can't be something that's trying to be everything for everybody. Really understanding what does success look like and how do we do that? For us, it's about improving quality. So making sure that the quality of our interventions and our outcomes are better. The quality of experience for people is better. We want to accelerate progress. So do things quicker, remove barriers, get rid of stuff that gets in the way, use the best practice, share it quickly, not just across Leeds, across West Yorkshire and way beyond West Yorkshire. You know, we go out, we talk to people, we share our experiences, the good, the bad, the stuff that hasn't worked. We can do this quicker, but we have to invest, we have to have focus, and we have to really drive it forward as a deep partnership. So I'm going to say just a little bit about the approach we've taken, and then I'm going to bring Michelle in, who's really led some of our programme approaches. So we've recognised a gap in Leeds. What we can see is that there's real passion from our partners to make a difference and focus on narrowing inequalities. And we know that if we do focus on bringing in a more diverse workforce and removing those barriers, supporting them to succeed, helping retain them successfully, we know that actually that has a really positive impact for everybody, not just the people in those communities, but much, much wider. So that investment isn't just about that narrow focus, it actually has a much greater amplifying effect. So the approach we took was to define that group. How do we want to start this work? And we started in a really holistic way looking in neighbourhoods, so working with local neighbourhoods to really understand what were their challenges, where were the opportunities for them to really think about health and social care as careers. We wanted to start as young as we could, so 16 plus, although we do lots of work with children right the way back to 4 years old in schools. This particular work is around young adults right the way through to retirees, thinking about how do we connect with those communities. We wanted it to have real opportunities for people, so not just talking about signposting people here or giving people a leaflet, but actually how do you turn that into a reality? What are those opportunities? some people might be ready for a job. How do we make that happen? Some people, it might be about education or training. How do we make that happen? For some people, it might be volunteering, it might be work experience. We've got to make it real. We wanted it to be about rewarding careers, so not just getting a job, not just ticking a box, not just handing people over to an employer and saying that's our bit done, but really thinking about that progression, that future, leaders of our future. How do we really create that pathway that goes beyond stepping foot into an employment opportunity? And how do we involve all of our diverse employers and partners, educators in that system in Leeds? So it's not just there's a little programme happening over here. It's if you talk to somebody in the University of Leeds, if you talk to somebody in the East Leeds project, community project, if you talk to somebody in Catch, they know about it, they're involved in it, they're committed to creating those opportunities. So I'm going to hand over to Shell to tell you a little bit about the work that we've been doing and the impact that we've had so far.
Thanks, Kate. So the Connected Communities programme that I'm going to give you an overview of is a bespoke rolling campaign focused on long-term engagement with priority communities within our city, and it's built around current employer and education-led opportunities. So as Kate mentioned, it's very much a strength-based approach, utilising our assets that already exist and leveraging the expertise across the partnership to bring about real tangible opportunities to make that difference. So in terms of engaging with our deprived communities, we absolutely started from that grassroots approach, so connected with assets that were already existing, working with charities that were already in those localities and asking the residents of those communities, what do you need and how do we make it accessible? So absolutely, that co-design, that co-delivery model right from the start. And with that, we looked at not just the barriers that those communities face, but also the root cause. So this is about a long-term commitment and sustainability. So to address barriers is great, but understanding and making the difference to the root cause has that sustainability element to it. So in terms of engagement, we went out into communities. So we didn't just rely on social media or flyers or leaflet dropping. What we did was we went out into areas of high footfall, whether that was a school using school networks, identifying local supermarkets, connecting and having those one-to-one face-to-face conversations with people. And that really led to a really diverse engagement campaign, to which actually led to 650 people being referred into the programme that I'm describing. We also looked to then co-design the opportunities, so what is tangible, what are the needs and wants of that community, and how do we connect them with opportunities from our providers and our education and employers. I'm going to just describe to you some of the impact and some of the change that this approach has led to. So this is about making change. We've absolutely disrupted recruitment methods across our partnership. What we have done in the city is develop our talent hub. So our talent hub is a citywide service that connects opportunities, whether it's employment, education training, volunteering or work experience. And it acts as almost a front page that hides the complexity of the system. So it's person-centred, it helps people navigate quite a complex system. What we have done is we've disrupted how partners connect in with local talent pools, and that is through alternative advertising. So again, thinking differently, not relying on social media or SNHS jobs or track or something similar, but actually going into the communities and using the assets that are already there. What we have done through this programme of work is we've brought about innovation and change. So we've disrupted local practices and policy. So what we were able to do through this piece of work is flip the recruitment model. So rather than think about whether the person is right for the opportunity, our focus is the opportunity right for this person? And it's putting the person first. We've also established a number of hidden talent processes across the partnership. So when we've gone into local communities, we have very diverse communities that bring about a lot of skills and experience, whether it's previous qualifications or work experience, maybe not from this country, but from their country of origin. And what we've been able to do is identify those hidden talents and fast-track them into opportunities across our system partners. Furthermore, what we have done through the proof of concept is embed values-based recruitment across the partnership. I'm just going to kind of highlight some of the data that's contained in the paper. So the impact that this approach has had on our local communities is staggering. So as I've said, we've had in over 850 expressions of interest through those local communities to be supported into an opportunity that's based on their ability, ambition and personal circumstances. We've supported 184 people into employment across 8 different career pathways within 5 different employers in the system. Through our supportive pathways, we boast a 95% retention rate of those people supported into employment, and I think that's testimony to our person-centric approach. So identifying, is the opportunity right for the person rather than the person right for the opportunity? We've supported 283 people into education and training, and we've supported 169 people achieve an accredited qualification. Of those that have been supported, 41% of candidates were long-term unemployed at the point of contact. I'm highlighting those statistics, which are brilliant, and I'm really proud to kind of share them here, but I think we've all heard today the impacts of that lived experience and that personalisation. So I just want to share with you Rachel's story. So Rachel resided in one of our local communities, and she was supported into employment through an apprenticeship. So Rachel has successfully completed her apprenticeship clinical support worker in one of our NHS organisations. And Rachel spoke about it was the first time she'd been supported into a career opportunity rather than just a job. So it's not a tick box exercise. She can absolutely see that career trajectory, and she has ambitions to go on and complete her nurse registration. She speaks at length about her increased confidence and self-esteem and how she's learnt new skills. And these skills are not just beyond the role of a clinical support worker, but it's the interpersonal skills, the communication skills, the listening skills that she takes back into her community and to her family, and the ripple effects that that has. She also references earning her own money and the difference that makes in terms of her choices, and how being in secure employment, it's improved her health and well-being. She has developed further colleagues and friends and networks to kind of help her achieve her potential. In terms of plans for growth, the approach that's detailed in the paper, and I've briefly referenced here, is built on research and evaluation. So this is academic research, but also practice-based research and evidence. And it's through that continuous learning that we improve our approach. So it is incremental, it's evolutionary. We continually do the horizon scanning for the even better ifs. And I think what we have shown through this programme of work is we do take the things that have worked well and we move forward with them, but we also acknowledge the things that haven't worked well and we take that learning and move forward. So in terms of next steps, we are doing some targeted work within 3 of the 6 priority wards that are in the city. We're growing our employer engagement, and we're working closely with our workforce planning in the city to build for the future. We're also looking at how we connect in with T-levels and apprenticeships, understanding that they provide real opportunity in terms of widening participation and supporting people achieve their potential. And then volunteering. As Kate referenced, we have a really strong volunteering community within the city, and we look to see how we can strengthen that following the launch of the voluntary strategy that happened in October. I'll hand over to Kate for reflections.
So Shell has described there the kind of really focused work that we've been doing, but as she said a number of times there, our aim has been about disrupting practices and policies and infrastructure that has created barriers for people. We have learned so much through this work. There is so much still to do. And what I really love about this is that this is a long-term commitment to a change in approach. This is not about a project. We didn't set this up with any additional funding. This was set up because partners were really passionate about making changes, and they committed their time, they committed their resources, they committed their efforts and their expertise to make this happen. And that real collaboration means that I have every confidence in its sustainability. We had a reflection session back in February, bringing partners together to explore their experiences, and given the financial pressures, what that meant for the future of this programme, which has absolutely attracted quite a lot of interest nationally as well as locally. I'm delighted to say that it was unanimous, the commitment that we would continue this work, because it is making such a difference. The statistics are really powerful. 95% retention rates after 12 months. You do not get that in direct recruitment for qualified, registered, people who are already committed to that profession. Never mind for people who are new to entering this kind of world. So I think the statistics do speak for themselves, but it's the stories like Rahel's which really kind of, take you by the kind of heart, I guess, and remind everybody why we do it. And I just wanted to share that with you, because we discuss it, as Rob said, we discuss it at the People Board. We share this widely. We learn from our partners in other parts of West Yorkshire as well. And it's very much an iterative process, committed to continuous learning. Thank you.
Thank you very much. Questions or comments?
Thanks so much. And honestly, I know this is the last item on the agenda, but I think it's probably one of the most transformative and the most exciting, for me anyway, because I see this work as really transformational, and that we can have that ambition to potentially roll it out across West Yorkshire, because we know what you said about retention is really important, but those furthest away from jobs, not being forced into a job that doesn't fit, which isn't going to work, but being carried through the process and being valued into a job that works for them, I think is a real game changer. And we've been trying to work in that way in the Combined Authority. I have devolved powers over the adult education budget. So, for example, when bus operators were saying we can't run reliable services because we don't have bus drivers, we were able to run a programme that went into communities furthest away from opportunity, in areas of deprivation, open a community centre that was closed, run a programme that would enable people to even think about potentially getting a job, let alone being a bus driver. And 50 have come out of that programme, with 60 more in the pipeline. And also we were told, another example is told by the telecoms industry, that they couldn't recruit. We were able to get 800, mainly men actually, young men furthest away from employment, into training, and nearly 90% have gone into these jobs, which are proper career jobs, well-paid jobs, money in their pocket, and aspiration and self-respect and so on. So I see the ability to be agile and to team and ladle some of that AEB money as a real opportunity here. And I know that with further conversations about devolution, that we will have more ability to be increasingly agile about what our sector needs. We have a workforce challenge in this sector, but we obviously have a solution, and being able to work across the whole of West Yorkshire, I think, could really turbocharge this programme. So there's lots to take away from this. One other point is our Future Goals website. 2.5 million views since it was set up. It's award-winning, really great outcomes, all ages, and I think that's also something to lift and shift and to support your work. And also, certainly people who are older coming back into careers, I think that's and those economically inactive currently is also a great opportunity. So very exciting. Thank you for your presentation. You're doing an amazing job at really changing people's lives, and that inclusive growth is perfect evidence of it, and that will help health and well-being. So thanks.
Thank you. Susan?
Yeah, thank you. And just back up what the Mayor said then about a great job that you're doing on that at Leeds Health and Social Care Academy. It's great work and so needed for all the things we're talking about. It is actually very much early help and prevention as well, isn't it? Getting people to workplace who might not necessarily be there, but obviously supporting the workforce in the health sector, which is really desperately needed at the moment. So just sort of remark about the paper, obviously, I think it's probably an oversight not having the Bradford Health and Social Care Academy in this paper, and I think there's one in Kirklees and Wakefield as well, Rob. So is that also on coming up at the People Board? Have they got a place at the People Board, would my question really there. And secondly, HR systems across NHS, I think I don't know if you've done this already on the People Board, but have you looked at streamlining our processes there and how long it is for somebody waiting to have their CV looked at, etc., etc.? Just from anecdotal evidence I've got that come through to me, they can wait months for replies and stuff, and obviously these are valuable people. Similarly with people from overseas who are maybe dentists, nurses, who might not have English as a first language, they might not be able to afford that course. Can there something go in from the health system to make sure they can get that course, then they can get into the health and social care workforce quicker? So the sort of things like that, are we looking at those things and making sure we're doing our utmost to be user-friendly really across the system? Thank you.
Yes, so I can probably pick up a couple of those points as I sit on the People Board. But yes, so in terms of wider partners across West Yorkshire, everybody has a seat at the table. So the academy work in other places is absolutely voices at the table. I guess Rob made a really good point. There's different infrastructures in different places across West Yorkshire. And in Leeds, we have got a kind of strong investment in the academy structure, which perhaps is not as deeply kind of replicated in other areas. But it's something that we learn kind of collaboratively from each other on. And I guess the kind of questions about what we're challenging around NHS is absolutely right. So we have some really great representation from NHS England and from other national bodies through that board where we can have some of those really difficult conversations. And I think to Shell's point earlier, our real focus is around changing the system. You know, it's not good enough to kind of remove barriers and put band-aids across the things that don't work. We've got to fundamentally change it, and that requires influence beyond the boundaries of West Yorkshire.
Yeah, just to add to that, I think Councillor Hinchcliffe, you've raised a really good point, which is how do we make sure that the work that's going on, we capture what's good, and do we want to be very directive about how we disrupt the policies and procedures, or do we want to let 5 places do what they can in their context? And on this agenda, it feels to me like there's so much good work that we probably want to be a bit more inquisitive about what each of the places is doing and is it sufficient. And I know that, there is really good work going on in Bradford, there's lots of capacity. There's not so much capacity in some of the other places. It's also clearly the case that some of our providers are doing some really good work in this space. So I think one of the actions from this, as a statutory body now, not a voluntary partnership, the People Board reports to us as a partnership. So it is a partnership body, it's not an ICB body, it's an ICS body, because it talks about the whole of the workforce. So we should really, I think, ask the People Board to consider how we're adopting and spreading the learning from each of the health and care academies, and how we're linking it into the Mayor's work around inclusive growth, and then bring a report back here to say, this is what we're doing and this is the difference it's going to make. Because, as we've heard, it is transformational. So I think that's the first thing, Chair, if we want to take that as an action. And then the second, on the international recruitment, yes, very much so. We've got a big piece of work supported by Health Education England about how do we collectively work to ensure that people can be recruited ethically from overseas, where we've got people who are already here who are qualified to work, how do we identify them and get them into the workforce, and how do we make sure that they're treated fairly when they do come into the workforce, because there's evidence that that isn't always the case. Again, that work will continue under the aegis of the People Board. It is obviously subject to capacity constraints, which may be affected by NHS England's merger and reductions to its budgets. But at the moment, we have capacity to do some work in that space.
Thank you. Fatima and Sahel both wanted to comment. I'm just aware we're well past our 5 o'clock, so if we can keep it fairly brief and then we'll wind up if that's okay.
Also, Chair, may I say that there's Transpennine problems, so if anybody's on the Transpennine, just maybe check your phone.
Yeah. Oh, right.
Does that mean I get a bit longer then? So, unsurprisingly, I love this. And what I really love about it is the aspirational nature and the fact that you can transfer your skill sets. As somebody who's always advocating for transferability of skills for carers, for example, and being able to facilitate them retraining, I think it's absolutely brilliant. I suppose there's a couple of areas where I'd love to support it to evolve it a little bit further. So one is, we're really trying to focus our retention strategies to keep people within work. And sometimes people want to change work for things like being a carer, for example. Is there an opportunity to evolve this in a way where we can make that impactful and keep our skilled workforce, is my first question. My second one is, we have got one of the best inclusive recruitment blueprints in the country, she says herself, even though she was involved in creating it. Is there an opportunity as part of this Rebel Alliance, which I'm fully available to join, that we can shift the dynamics of the way in which we recruit people too? Because I completely support helping people navigate the system. But what if the system's wrong and we need to change the system? And that's what we've been trying to do in West Yorkshire. So let's have a chat about that too. And then the final one is absolutely building on Mayor Brabin's point about working with the Skills for Business agenda. So we're doing a lot of stuff with the inclusion lens of developing capability for the leadership of tomorrow. And there may be some learning that we can split, but also to diversify the sectors. This is very much a health and care system focus. But we've got a thriving private sector that's going to be going next level under this lady's leadership. So let's develop the capability for the future too, if that's all right.
Thank you.
Thank you very much. So I think this relates to the fourth aim of the ICS, invest in the local development and local population. And it also relates to what Kathy was saying earlier about local investment. So I fully agree that people board would be the one to lead the facilitation on this. But I think it is more. I don't think there is any forum at the moment that is looking at that fourth aim, how we are doing it. And it's around, there is lots of good practice, for example. Yes, that's absolutely fine. But then there is, I think we should have targets. We should have targets to work towards. There are lots of things that we need to explore: apprenticeships, HR procedures, NHS jobs, our ways how we recruit, role of acute trusts. There's a lot of good practice that we shared with acute trusts. So it's what the role of WIAT and making it business as usual. Also the future workforce, because the AI, the automation, it's going to disrupt the jobs of today, but then it will create jobs of tomorrow. And if we are not, preparing our people for tomorrow's jobs, and then the inclusion health unit, for example, in Core 20+5 that we're developing and investing in those. So I fully agree with People Directorate, but I was thinking it might need a bit more, maybe a development session or something, where we do bring all people involved, universities, HR, People Directorate, everyone, and have a look at it, that how are we discharging our fourth aim or purpose. Thank you.
So personal view would be, let's focus on getting good work done through the People Board. And then Sahil's points around, this is a contributory factor to the economy and to improving people's lives under the fourth aim's right. Kathy's convened work on this across the north of England, actually, which we could build on. So, and I think that comes here, and also to the mayoral authority. So very much part of Jen Connolly's work, I think.
Thank you. So we're happy. agree to that approach that Rob set out in terms of tasking the people board with a bit of an analysis and challenge work. And Kate, I don't know if there's anything you want to add, but thank you very much for your presentation. I'm sorry you're on at the end, but thank you very much. So thank you very much, everybody. I've not had any notice of any other business. So close the meeting. Our next meeting is on 5th of March 2024. Thank you, everyone.